EPIGNOSIS, national level obstetrics case presentation. The gynecology case presentation went really well. We have judges, Dr. Aditya Nimkar sir from KEM Mumbai, consultant and fetal medicine expert. Dr. Radhika ma'am from Vanivilas Hospital, Bangalore Medical College and Research Institute. Welcome to the two judges. We are really privileged to have you as judges, ma'am and sir. With the permission of the judges, we shall start the presentation.
Sure.
Yes. So, once again, 6 minutes of presentation, 6 minutes of questioning and judging. So, 12 minutes in total, 10 participants are there. Let's keep it crisp and make it before 6 minutes of discussion. I know it's drilling goes on and on if there is no time limit. So, first participant, Ms. Varshita V from Vellore, 4th year MBBS. Can you switch on your, yeah, she has.
Yes,
share your PPT.
yes, sir. Satvik, you will be keeping the timing, right? Timer?
Yes, ma'am, I'll be keeping the timing.
Sure.
As soon as you start speaking, Varshita will start the timer.
Yes, sir. Is it visible, sir?
It is visible. Go ahead.
Good evening, respected professors and dear friends. So I am Varshita and I'll be presenting a case of Mrs. XYZ, wife of Mr. ABC. She is a 20-year-old female from RNE. She is a homemaker, studied till 12th standard. She belongs to class 3 according to modified BG Prasad scale. LMP 28/9/2024, EDD 5/7/2025. She is a primi gravida, married for 1.5 years, and her gestational age is 37 weeks and 5 days. Her blood group is A positive, and her date of admission was 17th June, and date of examination was 19th June. Chief complaints: the lady came with 9 months of amenorrhea and was admitted for antenatal care in view of high blood sugar levels. History of presenting illness: no history of increased hunger, thirst, or frequency of micturition. No history of vaginal discharge and itching. No history suggestive of recurrent UTI. No history of pain abdomen. No history of leaking or bleeding per vaginum. History of present pregnancy: the first trimester. She conceived spontaneously and her pregnancy was confirmed by urine pregnancy test at home after 35 days of amenorrhea, and it was later confirmed by scan. She was booked and immunized. No history of excessive vomiting and fatigue. No history of fever with rashes. No history of burning micturition or increased frequency of micturition. No history of pain abdomen. No history of leaking or bleeding per vaginum. No history of exposure to radiation or drug intake. Folic acid tablets were taken. First dose of TD was given at 3rd month. Regular antenatal care was done. Blood investigations were found to be normal, and first trimester scans were done and found to be normal. Second trimester, quickening felt at 5th month, and she continued to perceive fetal movements well. She was found to have increased blood sugar when OGTT was done during her next antenatal visit at 6th month, and she was advised proper regular diet and was put on oral hypoglycemic agent. No history of increased frequency of micturition and thirst. No history of increased appetite. No history of headache, dizziness, blurring of vision, epigastric pain, pedal edema. No history of pain abdomen, and no history of leaking or bleeding per vagina. Iron and calcium tablets were taken. Second trimester scan was done and found to be normal. Second dose of TD was given at the 4th month. Third trimester, she continued to perceive fetal movements well. Growth scan was done and the report was normal. No history of blurring of vision, headache, epigastric pain, decreased urine output, and swelling of feet. No history of bleeding or leaking per vagina, and regular antenatal visits. Menstrual history: she attained menarche at 13 years and had regular cycles of 28 to 30 days with 3 to 4 days of flow. She changes 2 to 3 pads per day, not associated with dysmenorrhea, and no history of passage of clots. LMP was 28/9/2024. Marital history: she was married 1.5 years back and a non-consanguineous marriage. Past medical history: no history of diabetes mellitus, hypertension, asthma, thyroid disorders, tuberculosis, epilepsy. No history of any recent surgery and medical intervention. No history of blood transfusion. No history of drug allergy. Treatment history: she was on medical nutrition therapy and metformin twice daily. Family history: no history of diabetes mellitus in the family. No history of bleeding disorder. No history of children with chromosomal anomalies or birth defect. No history of twin pregnancy in the family. No history of hypertension, asthma, tuberculosis, epilepsy. Personal history, she consumes a mixed diet, appetite is normal, and she gets adequate sleep. Her bowel and bladder habits are regular. No history of substance abuse, no history of use of contraceptives. General physical examination, the patient is conscious, cooperative, and well-oriented to time, place, and person. She is moderately built and moderately nourished, and no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Vitals, she is afebrile with a pulse of 92 beats per minute, regular in rhythm, normal in volume, normal in character, and no vessel wall thickening, no radioradial or radiofemoral delay, and all peripheral pulses are filled. Her blood pressure is 120/70 millimeter mercury, measured in the left arm at the level of heart in sitting position. Respiratory rate 18 breaths per minute. Her height is 167 centimeter, and her pre-pregnancy weight was 62 kgs, and her present weight is 73 kg. Her BMI was 22.23 kg per meter square, and her weight gain is 11 kg. Head to toe examination, oral hygiene was well maintained, no signs of nutritional deficiencies, no dilated veins over the neck, breast, spine, and thyroid appear normal. On examination of the abdomen, inspection, shape of the abdomen is globular, longitudinally distended. Corresponding quadrants move equally with respiration. Umbilicus is central, everted, with flanks full. Skin over the abdomen is normal. Linea nigra and stria gravidarum present. No scars, sinus, or dilated veins can be seen. Hernial orifices are intact. Palpation, no local rise of temperature or tenderness. Height of the fundus at 34 weeks is flanks full, and symphysis fundal height is 34 centimeter. Abdominal girth is 102 centimeter at the level of umbilicus. Leopold's maneuvers. On performing the fundal grip, I could feel a broad, soft, irregular, non-palatable mass suggestive of the breech. And on the lateral grips, on the right side, there were irregular multiple knob-like structures suggestive of the limbs. And on the left, there was a continuous curvilinear resistance felt suggestive of the spine. First pelvic grip, hard, round, independently palatable mass felt suggestive of the head. And second pelvic grip, converging, so the head is not engaged. On auscultation, fetal heart sounds are heard in the left spino-umbilical line. Systemic examination revealed no abnormalities. Summary, a 20-year-old primee, booked and immunized, socioeconomic class 3, married for 1.5 years, with a gestational age of 37 weeks and 5 days, was diagnosed as diabetic at 6th month by OGTT and was on a meal plan and oral hypoglycemic agent. Examination revealed a term uterus with a single fetus in cephalic presentation. The provisional diagnosis, primea gravida with gestational diabetes mellitus complicating pregnancy on oral hypoglycemic agents at 37.5 weeks of pregnancy with a single fetus in cephalic presentation.
Well presented, Dr. Varshita. Dr. Radhika, would you want to begin?
Yeah. So when was she started on OHAs, oral hypoglycemic agents?
After she was diagnosed, ma'am, at the 6th month onwards.
Okay. So initially, how do you go about once the patient is diagnosed as GDM? Well, how do you go about?
So we will perform the OGTT, and once it's above 140 milligram per deciliter, we will consider her as GDM, and we will start her on medical nutrition therapy, ma'am. So we will ask her to consume around 30 kilocalories per kg per day if she's of a normal BMI, and we will ask her to divide her meals into 3 meals and 3 snacks, and we will also ask her to consume her diet as 40% carbohydrates and 30 to 40% fat, and the remaining as proteins. And we'll encourage her to take more of dietary fibers. We can start her on metformin alongside, and if required, we can put her on insulin also.
Okay. So when do you start metformin? After medical nutrition therapy. So you told only about diet. Anything else you advise in MNT?
About exercise, at least 30 minutes of exercise a day she can do.
So after how many days or weeks of MNT, when you plan to start pharmacological management?
We can take, after 2 weeks, we can do a blood sugar level postprandial and fasting. So if the postprandial is more than 120 milligram per deciliter, and so then we can start her on medical management, pharmacological therapy.
So in this case, was it done like that?
Yes, ma'am.
MNT for 2 weeks and then followed by OHA.
Yes, ma'am. She was tried on MNT and then she was started on oral hypoglycemia.
Anything else you want to? Yeah, sir, please go ahead. Yeah.
Okay. Varshita, you mentioned a level of 140 and above when you spoke about OGDT right now while answering, ma'am. Are you sure it is 140?
So based on that DIPSI criteria of a single step test where we give 75 grams in 300 ml, so then 140 and above.
But then you mentioned that her diabetes was diagnosed on OGDT. So how did DIPSI come into the picture?
DIPSI promotes that one-step test, sir.
No, but you mentioned that the diagnosis was on the basis of OGDT, right? So how could you then quote the cutoff for DIPSI when you're speaking about the OGDT? Could you tell me the cutoffs for OGDT?
Based on the that is fasting is more than 95 milligram.
Are you
per
sure
day.
it is 95?
No, I think there is some confusion here, sir. Usually two-step is GCT followed by GTT, but in most of the South Indian states, what they do is they write one-step DIPSI test as OGTT. So I think she mentioned OGTT as a DIPSI test.
Okay, okay. Is that the case, Varshita?
You told DIPSI only as OGTT, or
Yes,
was
yes.
it actually OGTT? 4 values were taken.
Yes, I mentioned DIPSI as OGTT.
Okay, fine. So the oral glucose tolerance test, which you were mentioning that we do as a confirmatory test that we do in the period between 24 to 28 weeks, what are the 3 cutoff criteria where you take blood thrice? What are the cutoff criteria for that?
We take the fasting blood sugar, and then after the glucose load, we will take the 1 hour and 2 hour values.
What are the cutoffs?
So fasting is less than 105, sir.
Is 105 the criteria that we use in India? It is the NDDG criteria that you are quoting. That is not what we use in India. In India, we use the IIDS-PAG criteria, IID-PHG criteria. What is that criteria that we use in India? Okay, that's fine. You mentioned that your pregnancy is of 37 weeks, 5 days, which is almost equal to 38 weeks, and your baby is of 34 weeks. Would you call this on examination? Would you call that this patient might have FGR or this baby might have FGR, that is fetal growth restriction?
No, sir. Because the flanks are full, it could be because of a big macrosomic baby, so the uterus is close to term, so the flanks full and this
Okay.
fundal height is reduced.
If your patient has diabetes mellitus, I'm not saying gestational diabetes mellitus, I'm just saying diabetes mellitus. I'm not being specific about it. And also FGR. Usually there should be macrosomia, but if there is FGR, what would you suspect?
One is she could have had a pre-gestational diabetes, that is overt diabetes, where there could have been a vasculopathy due to which there is a uteroplacental insufficiency causing fetal growth retardation, or there could have been associated pre-eclampsia, sir. So again, there could be an FGR due to that.
Okay, very good. One last question. You mentioned about metformin. Any other OHA that we can use in pregnancy that is safe in pregnancy? Very close, very close. Glyburide. Okay, that's
Glyburide.
right. Dr. Radhika, any more questions from your end?
Yeah. Can you tell me what are the risk factors for ketoacidosis in pregnancy? Patients with GDM. Yeah.
She had overt diabetes. She's more
Yes.
to develop ketoacidosis, and if she had hyperemesis gravidarum, again due to excessive vomiting, she may develop ketoacidosis.
Anything else? Any other risk factors? Anytime else you frequently check for urine for ketone bodies in pregnancy?
I don't know, ma'am.
Yeah, I think you told me regarding the DIPSI, more than 140 is GDM. Any other cutoffs is there? Which is normal? What cutoff is normal in DIPSI test?
Less than 120 is considered normal, ma'am. 120 to 140 is impaired gestational glucose tolerance.
Gestational glucose intolerance. Okay.
Ma'am, we are past the time of questions.
Yeah, done. Yes, we are done.
Well done, Varshita. Well answered.
Judges, please note, among all the cases, gynac, what happened, everyone we're within the time limit, but this first time, the time taken is 6 minutes 13 seconds by the participant. Please note it.
Yes, sure. We can go ahead with the next student.
Yes. Next participant, Mr. Ashwin from Vellore. Please, yeah, thank you. Share your PPT. As soon as you start speaking, I'll start.
Okay. Just a second. So is it visible?
It is visible.
Yeah.
Your PPT is not as open. That's not open.
So now,
No, Ashwin.
We can see only your WhatsApp message.
so now is it visible, sir?
Ilakana, it's not. Just open the OBG case presentation. Only the chat is visible.
You minimize this chat box.
Okay, ma'am. So now is it visible?
Yeah, good. You can start. It is visible.
Good evening, respected judges and my dear friends. I am Ashwin from Final MBBS from Government Vellore Medical College. Today we'll see about the OBG case presentation. So patient details: Mrs. XYZ, 19 years, female from Katpadi, housewife, belongs to lower middle class, education of 12th standard, blood group of B negative, married for 1 year. Husband detail: Mr. XYZ, 28 years, daily wages by occupation. His blood group was O positive. Patient details: obstetric score, she is primary gravida. Her LMP was 24/9/2024. Unexpected delivery date is 0/1/7 and 2025. Period of gestation is 38 weeks plus 3 days. Chief complaint: she came with 9 months of amenorrhea and got admitted for her safe confinement of the pregnancy. History of presenting illness: she was apparently normal before 9 months and came for the safe confinement of her pregnancy. Present obstetric history: spontaneous conception, booked and immunized, total antenatal visits 4. Present obstetric history: first trimester. Pregnancy was confirmed by a urine pregnancy test in private hospital. History of nausea and vomiting. History of easy fatigability. History of folic acid intake was present. No history of fever with rashes. No history of radiation exposure. No history of bleeding per vagina. USG was done at 3rd month. Dating some NT scan was taken, and glucose standard test was done and came as normal. Second trimester, quickening felt at 5th month. Immunized with 2 doses of TD. No history of blurring of vision. No history of headache, abdominal pain. No history of leg swelling. No history of bleeding per vagina. History of blood transfusion for anemia on second trimester. Iron folic acid and calcium tablets were taken. USG ultrasound done at 5th month. Anomaly scan was done at normal. Glucose standard test was repeated and came as normal. Third trimester, able to perceive of fetal movements. No history of bleeding or draining per vagina. No history of lethargy. In that Coombs test was done and came as negative. Growth scan was done. This menstrual history: attained menarche at 13 years, a regular cycle of 3/30, normal flow, no passage of clots, changes 3 pads per day. Her LMP was 24/9/2024. Marital history: married at 18 years of age, non-consanguineous marriage, no history of contraceptive usage. Past history: no history of comorbidities, no history of previous surgeries. Family history: no history of diabetes, hypertension in her family, no history of hereditary diseases in her family. Personal history: consume mixed diet, normal bowel and bladder habits, no adverse social habits, no normal sleep pattern. General examination: consent was taken and examined in presence of female attendant. Patient is cooperative, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, pededema, and generalized lymphadenopathy. Vitals: A febrile, pulse 80 beats per minute, blood pressure 120/80 mmHg measured in right arm in sitting posture. Respiratory rate 18 breaths per minute. BMI 25.4 kg per meter square. Her height was 154 centimeter and pre-pregnancy weight was 61 kg. Weight gain during pregnancy is 8 kg. Breast, thyroid, spine are normal. Systemic examination: cardiovascular system, S1, S2 heard, no added zones. Respiratory system, normal residual breath zones heard. Central system, no focal neurological deficit. Local examination: after explaining the procedure with the female attendant, She is asked to empty her bladder. She is exposed from the zyphisternum to the pubic symphysis with adequate lighting and aerated room. On inspection, local examination on inspection, abdomen is longitudinally distended and uniformly. Umbilicus is in midline and everted. Flanks are full. Linea nigra and stria gravida is seen. All quadrants move equally with respiration. No scar, sinuses, red wings. Palpation, no local rise in temperature. Fundal height corresponds to between 32 to 36 weeks of gestation. Symphysis fundal height 35 cm. Abdominal girth 100 cm. Fundal grip soft. Bleepers fundal grip soft, bulky, non-independently palatable mass is spelled suggestive of breech. Umbilical grip right, smooth, curved, hard, uniform resistance is spelled suggestive of spine. Left, multiple nodules is spelled suggestive of limbs. First pelvic grip hard, round, and independently palatable mass is spelled suggestive of head. Second pelvic grip, both hands are conversing, suggestive of head is not engaged. Auscultation, fetal heart sound heard in spino-umbilical line. Summary, a 28-year-old primary gravida with B negative at 38 weeks plus 3 days of gestation, married to O positive husband, spontaneous conception, presented for safe confinement of her pregnancy with intact cum cyst negative with no other comorbidities. On examination, a single live fetus with fundal height corresponding to 32 to 36 weeks of gestation with flanks full, longitudinal light, cephalic presentation, and head not engaged came for institutional evaluation and delivery. Provisional diagnosis, a 21-year-old primary gravida at 38 weeks plus 3 days of gestation with single live fetus, longitudinal light, and cephalic presentation with intact cum cyst negative with good fetal heart rate without medical and obstetrical obligation came for evaluation having RS negative pregnancy. Thank you.
Thank you, Dr. Ashwin. Dr. Radhika, would you begin?
Yeah. So you mentioned that what is the gestational age now by uterine height?
38 weeks plus 3 days.
She's term pregnancy. Okay, but you mentioned 32 to 36 weeks, right? Per abdomen uterus is 32 to 36 weeks with fullness in the flanks.
It was, yes, ma'am, just below the zyphisternum. It's not up to the zyphisternum, it's below the zyphisternum.
Okay, sorry. She had history of blood transfusion in the second trimester. Was she evaluated for anemia during that time?
Yes, ma'am, she was evaluated for the anemia and blood transfusion was done. His hemoglobin was 8.2 at second trimester and now he was normal, 11 hemoglobin.
Fine. Can you tell me how do you evaluate a Rh negative pregnancy in the first visit, non-sensitized pregnancy?
In case of non-sensitive pregnancy, when the patient came, the first is blood group was taken, ma'am, whether she was RS positive or RS negative. Then husband's blood group also is also taken, whether she is RS positive. In case of husband is RS positive and mother is RS negative, and indirect cum test is done at the first week, ma'am, at the first visit, and once again repeated at the 28 weeks, ma'am. In case of it is negative, then we can go for the normal induction of labor at 38 to 40 weeks. And after the postpartum, we can give the anti-D immunoglobulin, which is 300 microgram, which is given postpartum prophylaxis to prevent the complication in subsequent pregnancies.
Okay, fine. Sir, please go ahead.
Yeah. Hi, Ashwin. Good question. Good case. First, tell me, you mentioned that your patient has been given anti-D, right? At 28 weeks.
No, sir, not given, sir. For this patient, not given ICD. ICD is negative, sir, but anti-D is not given.
Okay. Could you tell me a reason? I mean, in your practice, would you be giving anti-D or would you not be giving anti-D? What is the basis of your evidence for that?
So I asked to the patient whether about any costly injection was given to at the 28 weeks or before that. The patient told that she was not given, and
so would you give it? Does the evidence back
standard
administration of what is the recommendation? Do guidelines say that you should give?
Yes, at the 28 weeks we should give, sir, to prevent any antepartum. If there is any antepartum, for example, if any premature abortions or in case of any ectopic pregnancies, there will be more chances of fetal hemorrhage in antepartum. So in that case, we should be given for anti-D should be given, sir.
Okay, you can't be mentioning ectopic pregnancy or now that you have a term pregnancy anyway. Ectopic pregnancies are completely parallel event. Yours is a primary gravida. Okay, what is the mechanism of action of anti-D?
So anti-D is anti-D immunoglobulin, sir, which acts against the antigen, which crosses the, in case of positive fetus, the antigen which are exposed during the fetal maternal hemorrhage. So in case we give the anti-D immunoglobulin, it goes and binds and prevents causes agglutination. So that subsequent pregnancy, the fetal the exposed immunoglobulin does not cross the placenta.
Okay. You have given an anti-D at 28 weeks of gestation. Assume that you have given it. Would you still want to give it
Okay, sir.
postpartum? And why do you have to give it postpartum?
Still, we have to give postpartum because we can't assure that only 4 ml of only like 50 ml of fetal hemorrhage will happen. Suppose if case of any more amount of PPH like postpartum hemorrhages, we should give more amount. We should give more amount of anti-Ds. And
You're
postpartum
talking about
prophylaxis
amount. How do you measure how much of fetal hemorrhage has happened?
by using clear and acid dilution methods. Acid
What is the
dilution
name of the test?
clear acid dilution test.
Okay, clear Betke
Clear
test.
acid dilution.
Okay.
Yes, okay.
Any alternate use of anti-D that you know of apart from this isoimmunization thing?
No, sir.
Okay, one last question. You have a patient who is ICD positive at 28 weeks. How do you proceed?
So once if ICD positive, then we can then we have to check for the critical titer, sir. In case of critical titer is critical titer is 1 is to 16. In case of 1 is to 16, it crosses the critical titer. Then we have to go for the middle cerebral artery Doppler. So why it is taken? Because we have to see for the fetal anemia. So if it is more than 1.5 multiples of meridian, or it can be less than 1.5 multiples of meridian. In case of less than 1.5 multiples of meridian, we can be checking for alternate 2 weeks, and we can go for the term pregnancies. Suppose in case of more than 1.5 centimeter in MCV Doppler, then we have to evaluate. We have to do for chordosynthesis. In case of more fetal, in case of more anemia, to check how much amount of anemia is present. For example, in case in chordosynthesis, to check the fetal hemoglobin. In case of if very less, like less than 5.
Do you check
standard
fetal hemoglobin or do you check some other parameter? Remember, fetal hemoglobin is always going to be in the higher side. It is going to be 16, 17 or something. Do you check fetal hemoglobin on the chordosynthesis sample or do you check some other parameter?
Hematocrit, sir, fetal hematocrit.
Okay, what is the hematocrit? What is the cutoff for you to be transfusing blood?
Less than 30%, sir.
Okay, very good. Dr. Radhika, any more questions?
No, that's it.
No, sir. Time has been.
That's
Okay,
it.
great. Good. Well answered, Ashwin. Very well answered.
Thank you, sir. Thank you. Thank you, ma'am.
Thank you, Ashwin.
Thank you, sir.
Next participant, Ms. Shreya Hebbar, 4th year MBBS from AJIMS Institute of Medical Sciences. Please turn here and share your PPT.
Is my screen visible?
It is visible, share, but share the PPT.
Is it visible?
Not yet. Share.
Your desktop, yeah. Only you are visible as of now. You need to share your PPT. You opened and kept it open, right? You kept it open on the desktop?
Yes, ma'am.
Yeah.
Yes, ma'am. Like it's visible on my device.
Go back again.
Just
Go back
a
to the
second.
Zoom.
Can I try? Yes, ma'am.
Can we take the next candidate if this one is facing an issue?
If it's okay, let's do that. Best thing. We'll do that now. We'll do that, sir.
Yeah, we can go ahead with the next candidate. We can keep it ready by that time.
Shreya, it's okay. We'll sort out
You can
some
present next time. Yeah.
present after
Yeah,
this
yeah, yeah.
presentation. Yeah.
Okay.
So,
Varshani. Yeah.
Miss Varshani, 4th year MBBS from MMCRI. Please turn on your video and audio and share the
Sir,
screen.
sir, could you please make me the co-host, sir? I'm unable to share the screen.
I think you are the co-host. Varshani, what's your name in Zoom?
Varshani, sir.
I think it's Zoom user you have been. Okay, we'll make you co-host.
Okay. Hello, sir.
Yeah, please go ahead and share your screen.
Just a second.
Okay, okay, sir.
Really sorry for the inconvenience. Miss Samriddhi Arora, are you ready with the PPT? Samriddhi Arora?
Yes.
Can you present now?
Okay.
Yeah. Judges, please note, we have skipped 2 participants and we'll come back to the same. This is Miss Samriddhi Arora from LHMC, Delhi, presenting a case. Share the PPT. Okay, great. So 1 minute. Start now.
So I'm presenting a case of Mrs. X, 28-year-old female who was married for 6 years, resident of Old Delhi, educated up to 12th class, and she's a housewife by occupation, belonging to upper lower socioeconomic status as per modified Kuppuswamy scale CPI 2024. Her last menstrual period was on 3rd of December 2024, and her expected date of delivery is 10th of September 2025, with a period of gestation of 27 weeks and 4 days, and having an obstetric score of Gravida 7 and abortion 6. She is a booked case. She came to the OPD with a chief complaint of 6 first trimester pregnancy losses in the last 6 years. History of presenting illness. The patient is married for 6 years and has had 6 first trimester abortions in the past 6 years, each associated with lower back pain and spontaneous bleeding. She went to a private clinic nearby her home for the same complaint. She was advised multivitamin tablets and got investigations done for recurrent pregnancy loss. She did not get products of conception karyotyping or partner karyotyping done. She was not advised folic acid. She presented to LHMC Gynae OPD 5 months back with 1 month of amenorrhea immediately after getting her UPT positive at home. She was started on folic acid, tablet Ecosprin 150 milligram. Her ultrasound was done and cardiac activity was present. Routine ANC baseline investigations were done, which came out to be normal. Patient was advised more frequent visits in view of bad obstetric history. She came to the ANC OPD in view of routine checkup at 2 months of amenorrhea. Then she was admitted for safe confinement and for injection of enoxaparin in view of bad obstetric history. She was continued on tablet Ecosprin 150 milligram. She was advised hospital stay till delivery and to continue injection enoxaparin daily. There was history of lethargy and constipation present. There was no history of genital ulceration, generalized rash or lymphadenopathy. No history of polyuria, polydipsia or polyphagia. No history of thrombosis and clotting disorders. No history of irregular menstrual cycles. No history of breathlessness on exertion. No history of spotting or bleeding per vaginum. No history of burning, micturition or fever. Drug and treatment history, she was on tablet ferrous sulfate, on tablet folic acid and vitamin C, on injection enoxaparin, on tablet ecosprin, and tablet levothyroxine. History of present pregnancy. With a obstetric score of gravidas 7, abortion 6, the patient was conceived spontaneously and detected on UPT at 1 month of amenorrhea. Her period of gestation is 27 weeks plus 4 days, and there are no significant complications reported in the current pregnancy. First trimester, no history of fever with rash, no history of drug or radiation exposure, no history of excessive nausea and vomiting, no history of burning micturition. Folic acid tablets was taken. Received TD1 at 1.5 months. Level 1 scan was performed and cardiac activity was present. No history of bleeding or spotting per vaginum. All investigations reported to be normal except for serum TSH levels, which were reported to be increased. In second trimester, quickening was felt at 18 weeks. There was no history of polyphagia, polydipsia, or polyuria. No history of headache, blurring of vision. No history of leaking per vaginum. Received TD2, and level 2 scan was performed at 19 weeks of period of gestation with no gross congenital anomalies. History of previous pregnancies. So first abortion was in 2019 at 1.5 months. Spontaneous bleeding was present associated with pain. UPT was positive at home and ultrasound was not performed and no DNC was performed. The second abortion was in 2020 with the same history as first abortion. The third abortion was in 2021 at 3 months. The UPT was positive at home. Ultrasound was performed. Cardiac activity was absent. So DNC was performed at the private hospital for missed abortion. Abortion 4 was in 2022 with 2 months of amenorrhea. Spontaneous bleeding was present, associated with pain, and UPT was positive at home. Ultrasound was not performed, and no DNC was performed. Abortion 5 was in 2023 with 1.5 months. Spontaneous bleeding was present, associated with pain. UPT was positive, and ultrasound was not performed. No DNC. The sixth abortion was also having the same history. Menstrual history was normal. Gynecological history, there was no gynecological problem. Past history, she was a known case of hypothyroidism for 6 years, on levothyroxine for 6 years, with the dose changed in the pregnancy, with the current dose being 75 micrograms per day, but she was non-compliant and the TSH levels were poorly controlled. No history of TB, diabetes mellitus, hypertension, epilepsy, asthma, or renal diseases. No history suggestive of arterial or venous thrombosis in the past. No history of any surgery. Family history, there is no history of pregnancy loss in the family. No history of diabetes, hypertension, TB, or malignancy in the family. No history of bleeding disorders in the family. Dietary history was normal. Personal history, it was also normal, except for she was on chronic medication of levothyroxine for the past 6 years. Marital history was she was married for 6 years, non-consanguineous, and there's no history of contraceptive usage. Husband history, 30-year-old and clerk by occupation. History of pulmonary TB 7 years back. Not a known smoker or alcoholic, and no history of chronic illness or drug intake. On examination, the patient was conscious, cooperative, and oriented to time, place, and person. Her height was 154 centimeters and weight 54 kgs, with the BMI being 22.7 kg per meter square, which is normal. Temperature was 98.6 degree Fahrenheit. Pulse rate, blood pressure, respiratory rate were all normal. Thinning of hair was present. Pallor icterus, clubbing, cyanosis, edema, and lymphadenopathy were absent. The breast bilaterally symmetrical. There was no engorgement or discharge or nipple retraction. Thyroid, it was not visible, but palpable thyroid swelling was present. No engorged neck veins were present. On systematic examination, all the other systems examination came out to be normal. For abdominal examination, on inspection, the abdomen was uniformly distended, having linea nigra and stria gravidarum. Centrally placed umbilicus flat, no distended veins, sinuses, fistulas, or scar marks. The flanks were not full. On palpation, it was non-tender. The fundus corresponded to 28 weeks of gestation, with the symphysia fundal height being 28 centimeters and transverse diameter being 28 inches. The fetus was in a longitudinal lie. On the fundal grip, irregular, soft, not independently ballotable structures were present, suggestive of breach. On the lateral grips, irregular knobby structures were present on the right side, suggestive of limbs, and smooth curved structure was present on the left side, suggestive of back. In the third grip, that's a Publix grip, globular, hard, independently ballotable structure was present, suggestive of head. In the fourth, that is a deep pelvic grip, hands converged, confirming the findings of third grip and indicating that the head is not engaged. On auscultation, the fetal heart sounds are present in the left spino-umbilical line. Summary: Mrs. X, 28-year-old female, housewife, resident of Delhi, had an obstetric score of gravida 7, abortion 6, with period of gestation 27 weeks plus 4 days. She presented with a complaint of 6 consecutive spontaneous abortions in the first trimester. She is a known case of hypothyroidism on medication and poorly controlled, and on examination, palpable thyroid swelling was present. Provisional diagnosis: Mrs. X, 28-year-old female, gravida 7, abortion 6, at period of gestation 27 weeks plus 4 days, single intrauterine live fetus and longitudinal lie, having cephalic presentation with normal cardiac activity, having hypothyroidism with recurrent pregnancy loss, not in labor.
Well presented, Samriddhi. Dr. Radhika, would you want to start?
Yeah, Samriddhi. You told that the patient is admitted till delivery. She was advised to get admitted till delivery. Why is that?
Yes. Ma'am, it is because of the bad obstetric history. Also, she has to be given enoxaparin injection daily. For that, she was admitted till delivery.
But that's a subcutaneous injection, right? She can take
Yes,
even similar to insulin also.
yes, ma'am. But because of the previous bad obstetric history of 6 consecutive abortions, to keep her on check and also to monitor her TSH levels regularly and to see for her compliance of levothyroxine, she was admitted in the hospital.
So that's usually because enoxaparin is costly. They're not affordable to buy outside. But otherwise, it can be taken at home. So actually, hospital admission was not required for her. But yeah, it could be due to affordability issues. Okay. Can you tell me what are the causes for first trimester abortion? All of them were first trimester.
Yes, ma'am. Yes, ma'am. All of them were first trimester abortions. There could be endocrine causes like hypothyroidism, uncontrolled diabetes mellitus, PCOS, or increased prolactin levels. Then there could be the genetic abnormalities like aneuploidy or trisomies. Um, then there could be APLA syndrome, antiphospholipid antibody syndrome. Um, there could be inherited thrombophilias. So these are first trimester abortion causes.
Okay. So please go ahead.
Okay. Do you believe that this patient has had all those 6 abortions only because of hypothyroidism?
They're not really, because there could be some immunological causes as well, for which the patient is being given aspirin and enoxaparin prophylactically.
Okay. Why don't you think that you can, do you believe you can check for APLA profile, all the antibodies during pregnancy?
Um, the pregnancy, it is already an immunological state, so I don't think that we can correctly measure the antibody levels in pregnancy.
Okay.
Uh,
Actually, you can measure it. In fact, there is a new concept called as obstetric APLA syndrome, in which you can measure it in pregnancy and you don't need the criteria to be fulfilled twice over 12 weeks. So you can, as per the recent guidelines, you can check it. Okay. You have prophylactically started her on heparin. A lot of people do that, and the outcomes have been good enough. But is there any evidence? And secondly, how does heparin help? I mean, why not just start warfarin? By the way, warfarin is safe in pregnancy nowadays, below the dose of 5. So why not warfarin, which is cheaper, can be given as an oral drug, and why heparin? All you need is anticoagulation, right? So you can do it with a cheaper oral drug. Why not that?
because warfarin is a teratogenic drug.
No, it's not. Below 5 milligrams, you
And
can
time.
give it every day nowadays. So what is the reason? It's not
Um,
teratogenicity as a reason. What else?
Probably there are more studies on unfractionated heparin being safer in pregnancy.
Okay, it is not about that, but okay, we'll keep that discussion for another time. Could you tell me, you have a patient, what is the TSH level that you would want in a patient like yours who has recurrent pregnancy loss? What would be the range for your
Uh,
patient?
so in the first trimester, till 2.5 milli-international units per liter is considered normal, and in second and third trimesters, up to 3 milli-international units per liter is considered as normal.
Okay, what is the
Lower
dose?
limit?
Yeah,
Lower
lower
limit.
limit. Yes, yes. Lower
Range.
limit.
I am
You
not
told
sure
upper
of.
limit target.
Okay, you don't know. Okay. What is the dosing? How do you calculate the dose for levothyroxine?
So it's 2 microgram per kg per day, which is the
Two,
loading.
you would end up giving the patient iatrogenic hyperthyroidism. She'll be having tremors and all. It is 1 microgram, and if you have a thyroidectomy patient who has already had a thyroidectomy, then it is going to be 1.6. 2 is going to be a little too much. Okay, one last question. You mentioned about inherited thrombophilias. What are those? What are the other thrombophilias that you know
Um, Protein C and S deficiency.
of? Good. What else? Okay, no problem. Dr. Radhika, any more questions from your end?
That's it, sir. That's all.
Okay. Good, Samriddhi.
Thank you, sir.
Great presentation, but judges, please note, time taken by the participant, 7 minutes, 43 seconds.
Okay.
Next participant, 1 second. Next participant, Ms. Shreya Hebbar. Judges, please note, we have completed Samriddhi Arora. Now we are going to Shreya Hebbar and then Miss Varshini. So,
Okay.
yeah. Shreya, can you try now? Hi.
Yes, 1 second.
It's not working. I can.
Yeah, sir, it's showing error in mine.
It's okay. Wait.
Shreya, could you log out and log in again? Until then, we can move on to the next user. Acha, you are sharing? Okay.
Yeah, I'm sharing. It's visible, right?
Yes, it is.
Yeah, screen
Yes,
is
sir.
One minute. Shreya, as you present, I'll just keep moving.
Okay.
1 minute. 1 minute. Don't start.
Good evening.
Start now. Timer starts.
Good evening to the respected judges. Today, I'm going to be presenting the case of Mrs. ABC, who's 30 years old, from BC Road in Mangalore. She's an MCOM graduate and works as an accountant. Her husband's name is Mr. XYZ, who's 35 years old and is a BCom graduate and works as a survey officer. She has a parity index of para 1, living 1, and abortion 1. With last menstrual with last menstrual period of 5th of July 2024 and expected date of delivery 11th of April 2025. History of present pregnancy. A 30-year-old primary gravida who's on post-operative day 6 had underwent cesarean section on her own request. She had delivered at 40 weeks and 1 day of gestation. She has no history of fever, no history of pain abdomen, no history of excessive bleeding, no history of foul-smelling discharge per vagina, no history of burning micturition, no history of swelling of legs, no history of pain during breastfeeding, no history of pain and discharge from the surgical site. Birth history, antenatal history. Mother conceived spontaneously. Urine pregnancy test was done after 1 month of amenorrhea and found to be positive. Regular antenatal checkups and all scans were done. Tablet folic acid was taken. Mother had no history of excessive vomiting, pain abdomen, bleeding per vagina, fever with rashes, and exposure to radiations. Second trimester, quickening felt at 5th month of gestation. All scans and investigations were done and found to be normal. Calcium, iron, and folic acid tablets were regularly taken. TD booster was taken. Mother had no history of headache, blurring of vision, bleeding, and leaking per vagina. Third trimester, fetal movements perceived well. Regular antenatal visits were done. Calcium, folic, and iron tablets were continued. No history of bleeding and leaking per vagina. Natal history. Mother gave birth to a healthy baby girl on the 12th of April 2025 at AJIMS through lower section cesarean section, lower segment cesarean section in lieu of maternal request. Baby weighed 3.5 kgs and cried immediately after birth. Cord was cut and clamped, and injection vitamin K was given to the baby. Postnatal history, mother and baby are stable. Breastfeeding initiated on day 2 post-operatively, and baby feeds every 2 hours for 15 minutes. Baby passed stool and urine on day 1 with no NICU admission. Mother has passage of non-foul smelling, pale colored vaginal discharge suggestive of lochia firosa. No history of fever, cracking of nipples, and breast tenderness in the mother. Past obstetric history. Mother gives history of bleeding after 2 months of amenorrhea 1.5 years ago. She went to a private hospital in Bantwal following the same and found that she had abortion. So she had underwent dilatation and curettage. She has no history of post-procedural complications. Menstrual history. Mother had attained menarche at 15 years of age. Initially, she had regular cycles of 28 days, but she complains of irregular cycles since the last 5 years, in view of which she has history of consumption of medications for regularization of cycles before 4 months of current conception. She had 4 days of flow and changed 2 to 3 pads per day. She has no history of passage of clots and pain during menstruation. Marital history. Mother has been married since 3 years and it was a non-consanguineous marriage. She gives history of usage of barrier contraceptives for 1 year after marriage. Past history, no history of diabetes, hypertension, thyroid disorders, epilepsy, and asthma. No history of any previous surgical interventions and no history of any blood transfusions. Family history. Patient's mother is a known case of type 2 diabetes mellitus since 2 years and is on medications. No history of hypertension, epilepsy, or asthma in the family. Personal history. Mother consumes a mixed diet and has normal appetite. She has adequate sleep and regular bowel and bladder habits and has no history of substance abuse. Mother's diet history is suggestive of that she has a deficit of 390 kilocalories and 0.9 grams of proteins. General physical examination. Mother is cooperative and well-oriented to time, place, and person. She is moderately built and nourished. Weight pre-pregnancy was 59 kgs and pregnancy is 69.5 kgs, suggestive of a weight gain of 10.5 kgs. Height is 156 centimeters and mother's BMI is 24.2 kg per meter square. Vitals, pulse. Mother had 78 beats per minute with normal rate, regular rhythm, normal character of vessel wall, peripheral pulses felt, no radial and radiofemoral delay. Mother had blood pressure of 110/70 millimeters of mercury in the right arm in sitting position. She had respiratory rate of 14 cycles per minute, which is of thoraco-abdominal type. She is clinically afebrile. She has no pallor, icterus, cyanosis, clubbing, and lymphadenopathy. Mother has presence of edema up to mid-leg bilaterally, which is of pitting type. Breast, thyroid, and spine are normal. Obstetric examination, per abdomen examination, inspection, shape of abdomen is globular and all quadrants move equally with respiration. Umbilicus is central and inverted. No dilated veins or sinuses. All hernial orifices are intact. Linea nigra and stria gravidarum present. LSCS scar present just above symphysis pubis with no redness and discharge from the wound. Palpation, no local rise of temperature. Abdomen is non-tender. Scar tenderness is absent. Uterus is palpable at midway between umbilicus and symphysis pubis. Auscultation, normal bowel sounds are heard. Per vaginal examination could not be done. Examination, respiratory system, non-vesicular breath is heard with no added sounds. Cardiovascular system, S1 has to heard normally with no noise. Central nervous system, neurological deficits. Examination of the baby is placed by the mother side. The pulse rate of 1 beats per minute and is right. Baby weighs 1 kgs and has a length of 45 centimeters. Circumference is 30 meters and chest circumference is 30 centimeters. HC to ratio is 1:1. Head to toe examination. There is absence of pictures, hair, eyes, ears, skin, normal, no cleft, no chest and abdominal, genitalia is anal orifice, upper and lower limbs are normal with normal digits. Routing
1 minute, we'll sort it out.
That should be okay. Can you tell me your diagnosis?
Yes, ma'am. My diagnosis is a 30-year-old female post-operative day 6 with obstetric score of para 1, living 1, and abortion 1 has given birth to a healthy baby female through the procedure of LSCS on 12th of the April 2025 with no associated natal and postnatal complications.
Okay, that's good. So why do you think she's staying in the hospital on post-operative day 6? When do you discharge generally?
Ma'am, for LSCS procedures, we'll generally monitor them for at least 1 week.
1 week? After 1 week, they discharge the
Yes.
mother and baby? In your
Yes,
center?
ma'am. Generally, they.
How many days catheterization is done for uncomplicated cesarean deliveries?
Ma'am, 2 to 3 days, but I'm not sure about the number
Okay,
exactly.
fine. Yeah. So we'll assume that if this patient, when she was pregnant at term, she had come to you. You are the gynecologist. Okay. She asked for cesarean delivery and maternal request, CDMR. Okay. So would you go ahead and directly do it, or would you counsel her for vaginal delivery? How do you tell her what are the advantages, disadvantages of both?
Ma'am, I would recommend her to go through vaginal delivery because vaginal delivery has a lesser chance, like it has lesser period of stay in the hospital and is not associated with other complications. And plus, the mother can, like, she can undergo ambulation very early, and it will, and for subsequent pregnancies also, it will be beneficial for her. So I would recommend her if she goes through vaginal delivery.
Anything else? Any other advantages of cesarean versus anything else? In terms of complications or maternal deaths, anything else?
Yeah, ma'am, like intraoperative complications in C-section have a higher rate of chances than in vaginal delivery.
Okay. Sir, please, Dr. Aditya.
First of all, you mentioned no scar tenderness in palpation. You wouldn't mention of scar tenderness in a postnatal patient. That's an antenatal finding. You can instead say there is tenderness or no tenderness around the scar, around the region of that local wound, but don't call it a scar tenderness. It implies that the patient is still antenatal, first thing. Secondly, imagine now that your patient is completely normal, but if your patient is day 6 and day 4, day 5, day 6, and she has started to have fever spikes now, what would your next management be?
Sir, I will check her for her blood counts, and then I'll check for if she has any other symptoms like pain abdomen or any foul-smelling discharge, which can be indicative of puerperal sepsis.
Okay, what are other
And
foci that you would want to see of fever?
so like if it's varying throughout the day or if it's continuous or the type of fever, like.
Okay, but what are your different focuses, or what are your various causes, differentials that you have at this point? It's a day 6, day 5 classical fever.
So I would like to rule out either puerperal pyrexia or puerperal sepsis.
That's a very broad term. What are those specifics? What are those specific areas that you would want to examine? Which is the commonest cause of fever on a day 5, day 6 in a patient?
You mentioned
So
already loci is healthy.
UTI,
Anything else? Any other other than the unhealthy loci? Any other causes of fever? Common causes of postpartum fever. Postpartum patient. Now this patient says as fever, but wound is healthy and loci is normal. Any other causes could be there. Anything else you want to check? Breastfeeding mother, no?
UTI, ma'am. And if she has mastitis.
Exactly. The commonest cause of fever is going to be mastitis in such women. What else? What apart from mastitis? There is something that you have kept in your hand for 3-4 days. What is that going to lead to?
So there can be infection because of the
Sup-
cannulation.
Superficial thrombophlebitis, a better term for it. That can be one of the causes. Okay, you mentioned about
Yes, sir.
UTI. Could you tell me what is ERAS? ERAS, what is ERAS? If you
I'm
don't
not
follow ERAS,
sure
you're going to
about that,
increase
sir.
the risk of getting UTIs. There's a reason that I'm asking this question.
Mm, Not able to recollect it now, sir.
Okay, fine. The commonest cause of puerperal sepsis, the commonest focus of puerperal sepsis, which layer of the uterus?
Mm, So,
You have been mentioning lochia again and
so
again. So from where is the lochia being created?
sir, it basically consists of the casts and RBC casts and this one,
Exactly.
endometrial infection.
Exactly. What do you call as endometrial infection as?
Endometritis.
Endometritis. That is your commonest cause of puerperal sepsis. Okay, I'm done. Dr. Radhika, any more questions?
Yeah. In this breastfeeding mother, what contraceptive would you advise her now?
Ma'am, I would advise her to take
She's spacing, right?
progesterone-only pills.
Yes. Then
Yes,
yes,
ma'am,
progesterone-only
progesterone-only
pills.
pills. And I wouldn't encourage OCPs
Okay,
because
then
those will have a negative effect on this
yeah.
one.
What are the other options? Progesterone-only pill. Okay. They're not easily available. Anything else? Any other option she has? Which are easily
Ma'am,
available?
naturally, ma'am, lactational amenorrhea is like I can suggest it to the mother.
Yes. Okay. LAM has criteria. Okay. LAM is a good contraceptive method, and there are 3 criteria which are fulfilled. Anything else in the postpartum contraception you are thinking of?
I'm not sure, ma'am,
Okay,
right now.
good. Anyway, I appreciate that you have taken a postnatal case, but you should have been more prepared. Okay, that's good. Thank you.
Thank you, Shreya. Judges, please note again the time 7 minutes 40 seconds. Next participant, Miss Varshani, 4th year MBBS from MMCRI, Mysore.
Yes, sir.
Ready with, please switch on your video and share the PPT.
Okay.
Varshani, please make sure that you're sticking with the time limit.
Okay, sir.
These are like unnecessary loss
Yes.
of marks.
Okay, sir.
You
Sir, is
can
my
say
screen
past family and all that. You can just skip it by
Yeah, you
summarizing
can
it.
just go
Okay.
through it quickly.
Okay.
Prepare it for
Okay.
6 months, 6 minutes exactly.
Okay, ma'am. Ma'am, is my screen visible?
Your screen is visible. Just go to the PPT. Yeah, good.
Is it visible? I'll start, sir.
Hang on. Yeah, start.
Good evening, everybody. I'm Varshini, final year MBBS student of MMCRI. Patient particular, she is of 22 years and 30 days. She hails from Mysore. She's Muslim by religion. She has an obstetric score of Gravida 1, Para 0, Live 0, and Abortion 0. Her LMP was on 21st October 2024. Expected date of delivery is on 28/7/2025. Currently, she is in her 34 weeks of gestation. She is of A positive blood group, lower middle class according to modified Kuppaswamy classification. Age of the husband is 28 years. Chief complaint, she's a primary graduate with 8 months of amenorrhea who's a known case of hypertension on treatment and diabetes on treatment. She was admitted for evaluation management of pregnancy due to raised blood sugar values. History of presenting illness, a 22-year-old primary graduate with 8 months of amenorrhea. She was previously diagnosed with hypertension and diabetes on her first antenatal checkup during her first trimester of pregnancy. And her blood sugar levels were said to be elevated, and she was perceiving fetal movements well. No history of fetal edema, blurring of vision, or other symptoms suggestive of pre-eclampsia. No history of suggestive of asymptomatic bacteria like burning, exudation, etc. No history suggestive of pulmonary edema or cardiac failure such as chest pain, breathlessness, or palpitations. No history of hypoglycemic events like dizziness, sweating, etc. No history of bleeding per vagina. Antenatal history: first trimester, she has spontaneously conceived, and the pregnancy was through UPT, 1.5 months of amenorrhea. Pre-pregnancy weight was 53 kgs. It's a booked and registered case of pregnancy. Number of antenatal visits were 2 in the first trimester. Blood and urine investigations were done and was said to be normal along with the first trimester scan. Folic acid tablets and first dose of TD was administered. And blood sugar levels and BP when done on routine examination, it was said to be elevated, and she was started on insulin for diabetes, and she was prescribed medicine for hypertension. Other than these two values, first trimester history was uneventful. Second trimester was also uneventful. Iron folic calcium tablets were taken, continued. Second trimester scans, blood and urine investigations were said to be normal. Quickening was felt by the 5th month of amenorrhea. She has taken pre-antenatal visits in the second trimester. Other events are uneventful. No history suggestive of preeclampsia or pulmonary edema, cardiac failure, or ruptured placenta. Third trimester, antenatal visits were 2. Iron folic calcium tablets were continued. Insulin for diabetes and medication for hypertension were also continued, and fetal movements were perceived well. Third trimestral scan was done and it was said to be normal. Blood and urine investigations were done and it was normal. Total weight gain in pregnancy was 10 kg. She is currently 63 kgs, and there is no history of bleeding per vagina, burning, micturition, etc. No history of EC fatiguability, chest pain, dizziness, sweating, pain, abdomen, and no history suggestive of preeclampsia. Her obstetric history, she is married for 1.5 years. Her obstetric score is gravida 1, para 0, live 0, and abortion 0. She is conceived spontaneously after the 6 months of marriage, detected through UPT after 1.5 months of amenorrhea. She is currently in the 34th weeks of gestation. No history of infertility or oral contraceptive pill intake. Menstrual history, menarche was attained at 13 years. Her past menstrual cycles were normal and regular. No history of clots or dysmenorrhea. Her LMP was on 21st/10/2024. EDD is on 8/7/2025. Past history, no history suggestive of previous comorbidities. Family history is significant as her father was diagnosed with diabetes mellitus at his age of 45 years. No other comorbidities in any other family. No history of congenital anomalies or trending in the family. Personal history was satisfactory. She belonged to lower middle class according to modified Kuppaswamy classification. Treatment history, she is taking biphasic subcutaneous insulin of units 24, 00, and 14 for over diabetes mellitus since her first visit to antenatal checkup, and she's also under tablet labetalol 100 mg BD for chronic hypertension. Since the same time, diet history, her calories intake is adequate, and she's deficit by 10 grams of protein per day. Summary, 22-year-old primary gravida who's a known case of over diabetes mellitus and chronic hypertension, diagnosed in the first trimester of pregnancy during her first antenatal checkup, for which she is currently under subcutaneous biphasic insulin and tablets labetalol respectively. She came to OPD for regular antenatal checkup. Now she is admitted for management and evaluation due to raised blood sugar values. General physical examination, she is moderately built and nourished, conscious, cooperative, and oriented to time, place, and person. Her height is 156 centimeters. Her BMI is normal, calculated using the pre-pregnancy weight and gait, and no spinal deformities, no pallor, ectocyanosis, clubbing, lymphadenopathy, or edema. Rest of the vitals are normal. Thyroid and breast examination were normal. Systemic examination was also normal. Obstetric examination, patient was explained the procedure and privacy was taken, and privacy was maintained, and she was asked to empty her bladder. The exposure was from the Ziphy sternum to the pubic symphysis. Inspection, abdomen appeared to be over-distended, flanks were full, and skin over the abdomen appeared to be stretched and shiny. Umbilicus was averted and appeared to be pushed upwards. Linea nigra and stria gravida were present. No sinuses, scars, or dilated veins. All the herniated orifices were intact. Palpation, fundal height was 34 weeks. Symphysis fundal height was 36 centimeters from the pubic symphysis, and abdominal girth was 101 centimeters. Obstetric gifts, the manuals were performed with difficulty due to increased liquor. Fundal grip was suggestive of fetal buttocks because it was soft, non-palatable, and irregular mass. Lateral grip, I was not able to perform conveniently because of excess amniotic fluid. First grip, it was hard, palatable, round, regular mass was felt, suggestive of fetal head. Second pelvic grip, as the head was palatable, engagement has not occurred and convergence was seen. Second pelvic grip confirmed cephalic presentation. Fetal heart rate, it was not possible to record with stethoscope because of increased amniotic fluid. So I measured it with the help of Doppler, and it was found to be 156 beats per minute in the left side. Estimated fetal weight, according to Johnson's formula, was 3.56 kgs. Summary, a 22-year-old primary gravida with 34 weeks of gestation, along with the known case of chronic hypertension and over diabetes mellitus, both diagnosed in the first trimester. Cephalic presentation, not in labor, came for her regular antenatal checkup and was admitted for evaluation of pregnancy due to raised blood sugar values. And clinical examination, she was found to have polyhydramnios with an abdominal girth of 101 centimeters and symphysis fundal height corresponding to 36 weeks of gestation. Fetal heart rate was 156 beats per minute. Probable diagnosis: 22-year-old female, obstetric score, gravida 1 para0 live 0, and 34th week of gestation, singleton live intrauterine pregnancy with cephalic presentation, not in labor. Previously diagnosed case of chronic hypertension on labetalol and over diabetes mellitus on subcutaneous biphasic insulin. Clinically diagnosed polyhydramnios, admitted for evaluation and management. Thank you.
I haven't seen anyone present anything faster. I have missed half the things, but it's okay. Dr. Radhika, please.
Sorry, sir, because of
No problem. That's okay.
Really sorry.
Yeah, that's okay. Can you tell me how do you measure blood pressure in pregnancy?
Ma'am, the woman is asked to be in a relaxed state physically and mentally for 10 to 15 minutes before the measurement. It can be measured in two positions, in sitting position and in semi-reclining position of 45 degrees. Mostly sitting position is preferred, and the BP apparatus is to be kept at the level of the heart, because if it is raised, the BP measurement will be less, and if it is decreased at the level of the heart, there will be increase in BP levels. So it is maintained at the level of the heart, and the bladder should at least cover 80% of the circumference area of the arm, and the length should be 1.5 times the arm circumference area. And initially, the BP should be measured by palpatory method, and then it should be confirmed by the auscultatory method. And breath sounds of 5, Kussmaul breath sounds of 5 is being taken for consideration in pregnancy.
Okay. Okay, fine. In this case, she was diagnosed in the first trimester itself, right?
Yes, ma'am.
First trimester itself, she is diagnosed as this thing. Why did you say over diabetes? It was pre-pregnancy?
Yes, ma'am, because gestational diabetes is defined as a variable degree of glucose intolerance that is present in a woman for the first time during pregnancy, that is after 24 weeks of pregnancy. But here she was diagnosed at 6th week of conception when she presented. So I would like to consider this as over diabetes mellitus.
No, for hypertension, it is after 20 weeks. What about GDM? GDM diagnosis, can you repeat again?
From the variable degree of glucose intolerance that is present in a pregnant woman, which is identified for the first time in pregnancy after 24 weeks of gestation.
For GDM, there is no cutoff. There is no cutoff of gestational age. It can be anytime during pregnancy. Based upon the glucose values, you can say that probably it is over diabetes if it's more than 200.
Okay.
There's no cutoff gestational age for GDM. Okay. Yeah.
Okay.
Sir, please go ahead.
Varshini,
Yes.
do you know about the recent most FIGO classification or guidelines of hyperglycemia in pregnancy and the classification?
FIGO classification, sir.
Yes, 2017 classification. Do you have an idea about it?
Is it NDDG criteria?
No, it's not that. That's fine. No, not an issue. Your patient is a 22-year-old, fairly young patient who has chronic hypertension. Could you tell me what are the causes of chronic hypertension that you could be looking for in a young female?
So either it can be essential hypertension or it can be secondary hypertension. In case of secondary hypertension, there is no family history suggestive of any family members having chronic hypertension. So I would like to evaluate her for renal causes like glomerulonephritis, nephrotic syndrome, and endocrinal causes like pheochromocytoma, primary hyperaldosteronism, and serious causes like polyarthritis nodosa, and transposition of greater aorta. Coarctation of aorta. Though they are very rare causes, just that she's a very young female, I would like to consider secondary hypertension and evaluate her for that as
Any
well.
blood test for knowing one of the endocrinological causes apart from pheochromocytoma? Any
Sir,
other blood test that can also lead to hypertension in pregnancy and recurrent pregnancy losses?
Sir, collagen vascular diseases like SLE and
Something else. It is also a cause of hypercoagulation in pregnancy, thrombophilia.
HELLP syndrome.
No. Heard of homocystinemia?
Thrombophilia.
Yes, hyperhomocystinemia in pregnancy. It can
Okay.
occur.
Could you tell me what is the class of drug of labetalol?
Sir, it is a combined alpha and beta blocker. It helps in reducing the peripheral vascular resistance, hence
Okay.
decreases BP.
20 years ago, the drug of choice was alpha methyl dopa. It is no longer the drug of choice. Why has this happened?
Sir, because it had a higher incidence of intrauterine growth restriction and fetal bradycardia. Even labetalol has, but comparatively, it is lesser than methyl dopa.
Any maternal complications that it caused? Alpha methyl dopa.
Not sure, sir.
Okay. What is going to be a second line drug in hypertension in pregnancy?
I would like to consider calcium channel blockers, nifedipine.
Okay. And a third line? Is there any ACE inhibitor that you can safely use in pregnancy?
AC inhibitors are contraindicated in pregnancy.
Except one. Which one is that?
Not sure, sir.
Okay. Enalapril. That's fine.
No.
Okay. Dr. Radhika, any more questions?
Yeah, you mentioned about HELLP syndrome, right? That's one of the complication, right? HELLP syndrome. How do you make out that patient has hemolysis?
Ma'am, I would like to consider a peripheral blood smear. In peripheral blood smear, if there is blood cells or cystocytes, then it's suggestive of hemolysis. And as chronic hypertensive patients have 5% chances of developing HELLP syndrome, peripheral blood smear.
Any other test will tell you where the patient has hemolysis. One is peripheral smear. Good. Then
Platelet count of less than 1
No,
lakh.
for hemolysis. Ma'am is
or
asking for
hemolysis.
Bilirubin levels.
No. It's a part of some criteria. Name the criteria as well.
Is it Eden's criteria? Not sure.
Tennessee criteria. What is the test that you do for that, for hemolysis?
That's okay. Okay. Can you tell me what are the indications for termination of pregnancy in your case? When will you terminate?
I would like to terminate this case by 37 to 38 weeks of pregnancy because she has already developed polyhydramnios as a
Okay,
complication.
then any other indications? One is the term. Okay, then when will any other indication?
She has poor glycemic control. Insulin is not being taken properly. So, and also there is risk, as there is polyhydramnios, there is risk of congenital anomalies also.
Okay, fine. Yeah.
We are done. 6 minutes.
Yeah. Yes, done. Yeah.
Thank you, Varshini.
Okay.
So we're done with Shreya Hebbar, Varshini, and Samriddhi. Please know. Next participant is Miss Ushrita Krishna, second year student from Telangana. Ushrita Krishna, can you please turn on your video? Yeah, and start sharing the PPT.
Yes, sir.
What happened?
Ushrita, please take care of the time limit.
Yes, sir.
The remaining participants, please note, 5 participants are still left. If family history, past history, and personal history are unremarkable, you can summarize in a few seconds. That is best, I feel.
Yeah.
The entire negative history for that matter, ma'am, if you're okay with it. The
Yes.
negative history, we can just have a slide and we can skip it.
Ushrita, is there any problem? Can you share it? You share it now.
Sir, is my screen now?
Your screen is visible. You are visible. Just click on the share option and share your screen itself. And go to PPT.
All this general physical examination, systemic examination, they can skip. They can only mention vitals. Unless it's anything significant, you mention. Okay. If you're not able to share, we can ask the next user to start.
Just a minute.
Okay.
It's okay, Ushrita. You'll get the chance at the end. No, don't worry. We'll sort it out. I'll contact you. Hold on to it and try sharing. We'll move on to the next participant. Next participant, Mr. Divakar Koirala from Nepal, 4th year MBBS. Please, and share your PPT, Mr. Deva.
Is my PPT visible?
It is visible. Start. As soon as you start, timer will start.
Okay.
Judges, please note the
I am Divakar Koirala.
Participant name Divakar Koirala.
Okay.
Yes. Start.
Divakar Koirala from BPKIHS, Nepal. Miss ABC, 27 year, graduate to Para 1, 18 weeks, married, housewife, occupation, lower middle class family, residence of ABC, reason by Kirat, unbooked, LMP 24th February, and estimated date 1st December, unimmunized, with chief complaint of 18 weeks, amenorrhea, headaches for 3.
Just change the slides or make it a slideshow. It's in the first slide only.
Okay, so I'm sorry about that. It's not, is it changing now?
Just click on the slide and then go to slideshow.
Yeah, I'm changing the slide, ma'am. Is it not changing here currently? I'll try once again.
No, I'm seeing the first slide. What about others? Yeah.
Divakar, it's first open my slide.
So I'll directly.
Yeah.
I'll present only on slideshow is not showing for some reason, so I'll present directly.
Okay, fine.
This in particular, Miss ABC, 27 years, graduate to Para 1, 18 weeks, married, housewife, occupation, lower middle class, ABC resident, Kirat, by reason unbooked, LMP 24th February, and estimated date of delivery is 1st December, unimmunized, with chief complaint of amenorrhea for 18 weeks, headaches for 3 days, epigastric pain for 2 days, and blurring of vision for 1 day. The patient, 27-year-old with 18 weeks of gestation, presented to obstetric emergency department with 3-day history of persistent throbbing frontal headache, only given by paracetamol or other medication, reported epigastric pain described by constant dull ache in the right upper quadrant abdomen, which began to describe to the presentation. The patient was not associated with any food intake or did not radiate. Over the past 24 hours, she began experiencing blurred vision and photophobia. She denied seeing floaters or flashes, but reported generalized haziness of vision. There was no history of vomiting, fever, or urinary symptoms. The patient also reported decreased fetal movement in the last 24 hours. HOPP, a first trimester no folic acid test, only one ANC visit, pregnancy confirmed at 6 weeks by urine pregnancy test, dating scan at 8 weeks, no history of fever, ponymicturation, increased frequency or micturation. Second trimester, not immunized, quickening failed at 4 months, not taking iron and calcium, antenatal checkups were done irregular to remote location, and no first trimester bleeding, hyperemesis or infection reported. Fetal animal scan had not yet been conducted. She was not taking iron, calcium, and there was no history of proteinuria, but there was previous history of gestational hypertension. Menstrual history, menarche 13 years, irregular cycle, no clothes, don't use pads, use only clothes and change 3 times a day. LMP 24th February, EDD 1st December, no history of dysmenorrhea, menorrhagia, POG 18 weeks. Past obstetrics, gravid on Para 1, delivered at 36 weeks by spontaneous vaginal delivery 2 years ago, and pregnancy was complicated by gestational hypertension. Both was managed conservatively, and baby was appropriate for gestational age, healthy, no stillbirth, and no neonatal death. Past medical history of gestational hypertension and prior pregnancy, no history of diabetes, renal disease, epilepsy, asthma, or thyroid. Drug history not significant, allergy history not significant, personal history not significant, and contraceptive history not significant. See, inconsistently used barrier method, no other used method of contraception. Examination, acutely ill, lying in bed, uncomfortable due to headache and abdominal pain, build and nourishment, moderately built and nourished, level of consciousness, conscious and oriented. Blood pressure 168 by 112 mmHg, right arm supine position, pulse rate 102 beats per minute regular, respiratory rate 22 beats per minute, and temperature 99.2 degrees Fahrenheit in axillary, SpO2 97% on room air pallor. Present icterus, clogging sinuses, lymphadenopathy, edema present bilateral pitting, and dehydration not clinically evident. Thyroid and breast examination normal. Systemic examination cardiovascular within normal range. Respiratory no is clear on auscultation, no address sound or crepitation. CNS intact, however hyperreflexia was present on deep tendon knee jerk. And on abdominal examination, inspection, abdomen appears gravid, but no visible uterine contour, no scar marks, no distension, no skin changes. Palpation frontal height correspond to just below the umbilicus, uterine soft and non-tender, physio, sympatho frontal height 18 cm, abdominal circumference 28 inch, mild tenderness in the right upper quadrant, no uterine contraction or rigidity, auscultation, fetal heart sound difficult to localize with stethoscope, Doppler was used, and showed FHR of 140 ppm, and no signs of ascites or shifting dullness. And on summary, 27-year unbooked, unimmunized, gravid to Para 1 woman at 18 weeks gestation with severe headache, epigastric pain, and blurring of vision for the past 2 to 3 days. Had a history of gestational hypertension, no other significant history. On examination, appeared acutely ill, pallor and bilateral petechial humor, vital severe hypertension and tachycardia. Hyperreflexia was noted on neurological examination. Abdominal examination so uterine control at 18 weeks of gestation and right upper quadrant tenderness, and fetal heart 140 beats per minute. No signs of pulmonary cardiac failure. On investigation, there was anemia and low platelet counts and on peripheral ischemia, there are cystocytes. The urine proteins was 3+ and coagulation was 22nd. Ultrasound was not significant, and diagnosis of 27-year-old unbooked unimmunized gravid 2 para 1 at 8 weeks period of gestation with severe preeclampsia with HELLP syndrome and not in liver. Thank you.
Okay. Why do you think it is severe preeclampsia? What are the criteria for severe preeclampsia?
Ma'am, the criteria for severe preeclampsia is on first blood pressure more than 160 by 110, that is 160 systolic and 110 diastolic, and other features, systemic features like pulmonary edema or cardiac symptom or other low platelet counts on the basis of blood count, and other features like hemolysis or raised liver enzymes, and also CNS derangement. So since it was present, so it was severe preeclampsia.
But she has not crossed 20 weeks of gestation, right? By definition.
Yes, ma'am. But previously she had gestational hypertension, and currently and in between in inter-pregnancy period there was no hypertension. So based on that, I diagnosed it as severe preeclampsia.
Okay. I mean, any other criteria in her? She doesn't have any HELLP syndrome and all that, no?
Ma'am, she has hemolysis in.
She has HELLP syndrome.
Yeah, and low platelet 85,000 and.
Okay. So do you know what are the criteria for early onset and late onset preeclampsia? What gestational age is the cutoff to call it as early onset preeclampsia and late onset preeclampsia?
The exact data I don't know, ma'am.
Okay. What do you want to manage her? You already know that it's a HELLP syndrome. She has impending signs: headache, blurring of vision, epigastric pain.
I will counsel for immediate termination of pregnancy.
Immediate termination of pregnancy.
Yes, ma'am.
Okay. Can you tell me which gestational age you start measuring symphysiofundal height and abdominal girth? In pregnancy, routinely in all pregnancies, from when you start measuring?
Ma'am, usually after 28 weeks, ma'am. Usually after 28 weeks. Along
both? Both of them? Symphysiofundal height and abdominal girth?
Ma'am, symphysiofundal height we can do after 12 weeks, but abdominal girth usually after 28 weeks.
Okay. Here there was no need to mention both actually in this case. Okay.
Yes,
Sir, please go ahead.
Yeah. Hi, Devakar. You mentioned that the patient's temperature is 99.2 Fahrenheit. That makes her febrile. Have you tried to evaluate the cause of her fever?
Sir, it was done in evening, sir. So 99.9.
In the evening, 99.2 at any point in the day is fever.
So 90. Okay. So I did not try to evaluate the fever. So I thought because 99.
No, that's fine. Now just let's assume that she does actually have fever. You have a patient who is having headache, throbbing headache. She has fever. Think of something that connects
meningitis.
them. Meningitis. Okay. Anything else?
Meningoencephalitis.
Okay. Anything else?
Urinary tract infection.
UTI. Okay. No, not really, but okay. You mentioned that she has blurring of vision.
Yes,
Could
sir.
you tell me what are the causes of visual disturbances? What are the causes? What is the pathophysiology of visual disturbance in severe preeclampsia?
There are two pathophysiologies, sir. The first one is based on vasogenic pathophysiology. Since there is a destruction of endothelial cell, so there is presence of retinal ischemia. So that is the first pathophysiology behind the visual disturbance. The second is loss of cerebral autoregulation. So loss of cerebral autoregulation might affect the occipital cortex blood supply. So that would also may lead to blurring of vision.
You started correctly with the vasogenic part, but then the vasogenic part that actually is not retinal ischemia, it is vasogenic edema in the entire brain and especially in the occipital lobe. Okay. Something about the retina that you were mentioning, it is not the ischemia, it is something else. So do you want to reattempt that one? What happens to the retina in a patient with preeclampsia?
Edema, sir. Papilledema.
Papilledema, yes, one thing. And one more thing, any type of retinopathy?
Retina.
Any specific type of retinopathy? Since you have mentioned retina anyway, you took the viva to that direction.
Yes, sir. Yes, sir.
Anything?
central retinal artery occlusion, sir.
No, it is Piotr's retinopathy.
Amaurosis, sir. Okay, sir, not that one.
No, it is Piotr's retinopathy.
Okay, sir.
One more last question.
Yes, sir.
What are the various, rather than that, how is the earliest point of time that you can start having pre-eclampsia in a patient, and why?
Sir, I would say since 12 weeks. So because that was the starting of the invasion of the cytotrophoblast
Very
in the
good
spiral
answer.
artery.
Good answer. Good answer. Yes. Dr. Radhika, would you want to continue?
No, that's it, sir.
Okay.
We'll finish.
Thank you very much. Thank you very much, ma'am.
Thank you, Dr. Divakar. Next participant, Ushita will come to you. Hang on till there. Miss Sinchana, 4th year MBBS, AJ Institute of Medical Sciences. Sinchana, can you share the PPT? Try sharing the PPT.
Yeah. Am I audible?
You're audible.
Yeah, just a second. Is it visible?
It is visible. Start.
Please stick to the timing.
Yes, sir. My patient is Mrs. XYZ. She's 26 years old. A housemaid by occupation from Kullai, Mangalore. Her husband is Mr. ABC, who's 30 years old. He's a coolie worker. Socioeconomic status is lower middle class. Her obstetric score is G3P2L2. LMP is 19 December 2024 and EDD is 26 September 2025. Her period of gestation is 26 weeks. Date of admission is 18 June 2025 and examination was done on 19 June 2025. Her chief complaints were easy fatigability since 1 month and breathlessness since 1 week. History of presenting illness. Patient was apparently normal 1 month back, after which she developed easy fatigability. It was insidious in onset and gradually progressive. Before it was only on exertion, but now even on doing household chores. Patient gives a history of breathlessness, insidious in onset and gradually progressive. It aggravates on walking for around 100 meters, but is relieving on rest. Breathlessness is not associated with coughing, wheezing, palpitations, or chest pain. No history of generalized swelling, headache, or blurring of vision. No history of blood in sputum or blood in vomitus. No history of bleeding PV or leaking PV. No history of blood in stools or bleeding per rectum. No history of any worm infestation. No history of any fever with chills or rigor. Blood in the urine or burning micturition. No history of yellowish discoloration of skin. History of presenting pregnancy, first trimester. She conceived spontaneously and pregnancy was confirmed after 1 month of amenorrhea. First trimester scans and blood investigations done and said to be normal. Folic acid tablets were not taken regularly. There is no other history. Second trimester, quickening was felt at 4th month and she continues to perceive fetal movements. Second trimester scans were done. Blood investigation has revealed that her hemoglobin is 8 gram per deciliter. 2 doses of TD is taken. Iron and calcium tablets are not taken regularly. No other history. Past obstetric history. Her score is G3P2L2. One healthy female child weighing 2.9 kg, who's 4 now, and there is no other complications. Healthy female child, 2-year-old, birth weight was 2.5 kgs and no other complications. Menstrual history, everything is normal. Marital history, married at the age of 20 years, married life of 6 years and non-consanguineous marriage. No history of usage of any contraceptive methods. Past history is unremarkable. Family history is unremarkable. Her personal history, she's a vegetarian. Appetite is normal, sleep is adequate, bowel and bladder habits are unaltered. No history of any addictions or substance use. Her diet history was taken by 24-hour recall method. Calorie consumption is 2,200 kilocalories per day and protein was 70 grams per day. History who is G3P2L2 at 26 weeks of gestation has complaints of fatigue and breathlessness on doing household chores. History iron and folic acid tablets not taken regularly. Second trimester blood investigation revealed low HP levels. Diet is low in iron-rich foods and calorie deficit of 370 kilocalories per day. General physical examination, everything is normal except she has the vitals are normal. BMI is also under the normal limit. Abdominal examination. Patient is examined supine position with knees flexed in a well-lit room. Verbal consent was taken. She is exposed from sternum to pubic symphysis. Inspection. Abdomen is globular, uniformly distended. All quadrants move equally with respiration. Umbilicus is central and everted. Linea nigra and stria gravidarum are present. No other scars, sinuses, or dilated veins. Palpation. Inspective findings are confirmed. There is no local rise of temperature. Symphysis height is 26 centimeters, which corresponds to the gestational age. Fetal parts were just palpable. Auscultation 130 beats per minute heard in the left spino-umbilical line. Systemic examination, everything is normal. Summary, a 26-year-old with to L2 at 26 weeks of gestation with a single lightus came with complaints of fatigue and breathlessness. There is history of irregular consumption of iron and folic acid tablets. Second trimester blood investigation revealed low HB levels, that is 8 gram per deciliter. There is reduced consumption of iron-rich foods and there is a deficit of 300 kilocalories per day in her diet. On examination, present. Provisional diagnosis, 26-year-old female, G3P2L2 at 26 weeks of gestation with single life fetus, no signs of failure, suggestive of moderate anemia in pregnancy under further evaluation.
Okay. Can you tell me how do you say it's moderate anemia?
Ma'am, according to the classification, if it is less than 7 gram per deciliter, then it is
yes,
severe.
that's by investigations, right? Mild, moderate, severe,
Yes,
very severe, it's by
by
investigation. On examination, can you say it's mild anemia, moderate anemia, severe, very severe?
It's then be paleness seen on the palms, which we can consider as a severe form of pallor. But if it is only in the lower palpebral conjunctiva and the nail beds, then it might be moderate.
Okay. Can you tell me what are the risk factors for anemia in your case? What has caused her anemia?
First of all, it can be her multiparity because this is her third pregnancy. And the age gap between each pregnancy is also less, just 2 years. And another thing is she's not taking iron and folic acid tablets regularly. And her diet is so low in iron-rich food, so that can be a cause.
And she has not taken iron and she's non-compliant basically. Is it non-compliance or intolerance?
Yes.
She's not taking iron.
Non-compliant.
She's non-compliant. You're sure? Did you ask her
Yes,
for side effects? She never had any side effects with the tablets.
No, ma'am. Yeah.
Oh,
I asked her about it.
okay. So please go ahead.
Regarding ma'am's question, continuing that, regarding compliance, is there a way she'll to always be telling you that yes, she is compliant, but is there a very objective way of knowing whether she's compliant or not? Which question can you indirectly ask her?
We can ask her about the color of her stools.
Okay,
Because
very
if
good.
she's
Good enough.
compliant, then there'll be.
Yes, good. A lot of old timers used to say that you should be giving patients, antenatal patients, Jaggery to increase their iron load. Is that the right thing to do? Yes, no.
Yes.
Are you sure?
I think so.
See, the amount of Jaggery that is required to fulfill your iron demands in pregnancy is so high that you would end up giving the female gestational diabetes mellitus. And hence, that is not an ideal thing to do. Now, imagine that you are working with an ASHA worker who works in a very peripheral area, who understands not much. And the people she is working with are even more underprivileged and illiterate. What is the easiest way to tell them about foods that contain iron? What is an easy way of recognizing foods that contain iron?
Mainly nuts and green leafy vegetables we can tell them to consume.
Are green leafy vegetables the best things that you can recommend for patients with anemia? In fact, green leafy vegetables contain tannins that is going to impair your iron absorption. Any way of knowing which vegetable? Chickpea. Oh, chickpea again. Chickpea is in the same conundrum as jaggery. Okay, so whenever you cut any fruit or any vegetable, any fruit that turns black on exposure to air is the one that contains plenty of iron. Okay. First trimester, can you give parental iron?
First trimester, actually it's not recommended, but if it is less than 5 gram per deciliter, then we can give parental iron.
If your patient has anemia of less than 5, which is almost going towards severe anemia, I would not want to wait for that parental iron to act in first place. It will be blood transfusion
That
anyway.
sounds.
And secondly, no, you cannot give parental line in first trimester because it is theoretically teratogenic. It leads to free radical damage to your DNA. Okay. Which is that one, you have a lot of money, your patients have a lot of money. Money is not a constraint. Tell me that one drug that you can give as a parental line, which is now evidence backed, which is the best drug that you can give parental line.
Ferric carboxymaltose.
Okay, very good. Good answer. Radhika ma'am, any questions?
Nothing, sir. Can you tell me what is a prophylactic iron therapy? How much you give? When do you start? Prophylactic iron therapy. Routinely, what is given
Prophylactic,
in pregnancy?
we start from 14 weeks of pregnancy. We continue it throughout the pregnancy, and she should take it 3 months after the postpartum as well. It will be
Months
100 milli,
Earlier
100
it was
milligram
100.
of elemental iron. Now it's 60 milligram of elemental iron along with the 500 micrograms of folic acid. It's a iron and folic acid tablet.
Okay. Can you tell me duration of erythropoiesis?
It is no, I'm not sure.
From coronavirus to reticulocyte count.
1 week.
Okay, one last question that I have. Sinchana, just tell me, is there any difference in the dose of iron in a blue capsule and a red capsule given by Anemia Mukta Bharat?
Yes, sir. The red tablet is iron along with the folic acid,
No,
but the
both are
blue
the
one
same.
is.
Both have the same composition. Then just tell me, why is there a different color to them? No problem. Radhika ma'am, any more questions?
That's it. Yeah. Thank
Okay.
you. We'll
Thank
go
you,
ahead with that.
Sinchana.
Yeah.
Thank you, sir. Thank you.
Thank you, Sinchana. Next up, Ms. Sai Nitya Nidi, 4th year MBBS from KMCRI Hubli. Can you please switch on your video and share your picture?
Am I visible and audible?
Yes.
Thank you. Ma'am, is my presentation visible?
Yes, it's seen.
Yes, thank you. Good evening, everyone. So this is my case. Here is a patient, Mrs. ABC, a 25-year-old, hailing from Hubli. She is educated till 10th standard and is homemaker by occupation, and she belongs to lower middle class. Her blood group is O positive, and date of admission is 9th June 2025, and date of examination is 11th June 2025. Her LMP is 1st October 2024, and her expected delivery date is 8th July 2025. Her obstetric score is gravida. Husband's name is ABC, age 30-year-old, is laborer by occupation, and his blood group is B positive. Coming to history of presenting illness, she is a primary gravida with 9.5 months of amenorrhea, perceiving fetal movements well, came for regular antenatal checkup. There is no history of pain abdomen, no history of leaking or bleeding per vagina, no history of pedal edema, headache, and blurring of vision. Obstetric history, age at marriage is 21 years and active married life is 4 years. It was a non-consanguineous marriage. History of present pregnancy. First trimester, it was spontaneous conception. Pregnancy was detected by UPT after 1 month of amenorrhea at nearby PHC. She was booked and immunized. Routine investigations were done and reports were found to be normal. First trimester scans were done and was found to have twin gestation. Folic acid supplementation were taken and it was uneventful. Second trimester, quickening was felt at 5th month. Iron, folic acid, and calcium supplements were taken. Routine investigations and scans were done and were found to be normal, and it was uneventful. Third trimester, fetal movements are well perceived. Routine investigations and scan done and found to be normal. Iron, folic acid, and calcium supplements were taken and is uneventful. Menstrual history, age at menarche is 13 years. Cycles were regular. There is no history of dysmenorrhea, menorrhagia, and passage of clots. Last menstrual period is 1st October of 2024, and expected delivery date is 8 July 2025. Past history, it's not significant. Family history is not significant too. She does not have a history of twin pregnancy too. Personal history, patient is on mixed diet, consumes both vegetarian and non-vegetarian food. Appetite is normal and sleep is reduced due to increased frequency of micturition, and she also complains of constipation. Coming to examination, general physical examination, she's conscious, cooperative, oriented to time, place, and person. She's moderately built and nourished. Vitals, pulse rate is 90 beats per minute and regular. Blood pressure is 120 by 80 mm of Hg measured in setting position. Respiratory rate is 16 cycles per minute. Temperature is, she's afebrile. Pre-pregnancy weight is 60 kgs and height is 1. Her BMI is 26.66 kilogram per meter square. There is no pallor, icterus, clubbing, cyanosis, edema, and lymphadenopathy. Breast pan and thyroid examination are normal. Other systemic examinations are normal. Coming to per abdomen examination, inspection, abdomen is uniformly distended, umbilicus is central and everted, linea nigrans stria gravidarum are present, no scars, sinuses, or dilated veins. On palpation, there was no tenderness or local rise of temperature. Fundal height corresponds to 36 weeks and symphysis fundal height is 38 centimeters. Abdominal girth at the level of umbilicus is 104 centimeters. Obstetric grips were done. A fundal grip, I could feel a hard ballotable mass felt on left side, suggestive of fetal head, and soft broad mass felt on right side, suggestive of fetal breech. Lateral grips, there were multiple fetal parts felt, and first pelvic grip, there was a hard, non-ballotable globular mass felt suggestive of fetal head. Second pelvic grip, fingers are converging. Auscultation, two distinct fetal heart sounds are heard at two sides with silent area in between. They were confirmed with handheld fetal Doppler. Summary, a 25-year-old primary gravida came with gestational age 38 weeks and 5 days of gestation and perceiving fetal movements well for regular antenatal checkup. Her vitals are normal and on abdominal examination, multiple fetal parts are felt. Two distinct FHs heard too. Provisional diagnosis, a 25-year-old primary gravida with term pregnancy came for regular antenatal checkup. On palpation, multiple fetal parts were felt and two distinct fetal heart sounds heard, suggestive of twin pregnancy.
What is her gestational age accurately? You mentioned 9.5 months of amenorrhea, then 36 weeks and 38 weeks.
38 weeks, ma'am.
By date, she is 38 weeks, right? As per your date of examination, you mentioned 9.5 months of pregnancy, but date of admission and our expected date of delivery. You have examined her 1 month before delivery, right?
Ma'am, I had examined her, but like gestational age, I've corrected it to today, ma'am.
38 weeks. Okay, she is term pregnancy, 38 weeks, right?
Yes, ma'am.
Okay, clinically, how do you say that it is a multiple pregnancy?
Ma'am, clinically, first we perform examination, ma'am, Leopold's maneuvers. And if there are multiple fetal parts felt and more than 3 fetal poles felt, then we can confirm it as multiple pregnancy. And if there are multiple FHs heard at different sites with the silent area in between, then it can be confirmed. It can be also confirmed by investigations, ma'am, ultrasonography and fetal.
Okay, fine. So can you tell me what is iron requirement in multiple twin pregnancy?
Mm,
She's been coming regularly. Should she
Yes,
receive
ma'am.
same iron
Ma'am,
tablet or
for
will be given
normal
tablets?
for normal pregnant women, it is 60 milligram tablet that we give. But for twin pregnancy women, there is requirement of 100 milligram. Like the tablet we prescribe is two times of normal requirement. 100 milligram to
She was
120
taking 2
milligram
times
of
a day.
iron.
This patient was taking 2 times a day.
Yes, ma'am.
Iron?
Till like now she has discontinued, ma'am, but till 2 weeks before she was taking the tablets.
Okay. Sir, please go ahead.
Any idea, Sai, about what type of twin pregnancy is this?
Sir, I was not able to look at the scans, sir, so I couldn't.
Okay, but you must have seen the file now, so just tell me.
Uh, Sir, it was DCD.
Okay, DCDA. When would you ideally want to terminate this female?
Sir, this female, after 36 weeks of gestation.
But then she's 38 already, so what's now? What's next? And by the way, at 36, would you terminate a baby, DCDA baby?
Sir, if she comes with labor, then we terminate
Yeah,
it,
of
sir. But
course.
it is not.
She's
No,
in labor.
labor is different. What are the different gestational age you want to terminate? Like for MCDA, MCMA, DCDA, what are the gestational age? Ideal gestational age when you want to deliver them unless they go into labor.
Yes, ma'am. I'll make it clear. For normal pregnancy, it is around 40 weeks. For DCDA, it is 38 weeks. For MCDA, it is 36 weeks, ma'am. And for MCMA, it is 32 weeks, as early as we can.
32 to 34.
Yes.
That's the range. Okay. What do you think is worse to have, DCDA or MCDA?
MCDA, sir.
Okay. And all those classical complications that you have read of TTTS, PAPS, who are they majorly found in MCMA or in MCDA?
MCMA, sir.
Are you sure? MCMA.
Yes, sir. Because there is increased free vascular anastomosis between the two fetuses.
No, in fact, it is classically seen in MCDA fetuses because in MCMA there are neutralizing connections that are present. Anyway, now that you have mentioned, what are the complications that you dread in MCMA?
So twin-to-twin transfusion syndrome, twin
No,
reverse
just
arterial.
now I said that in MCMA it won't happen. In MCMA, monochorionic monoamniotic, what is the deadliest complication?
Why are we terminating at 32, 34 weeks? Why should we terminate early? What complications are you worried?
Cord polyps.
Something, they are in the same compartment, they are in the same amniotic membrane. Cord entanglement.
Yes, sir. Yes, sir.
Okay.
Cord.
Next question is going to be in a patient with what is that treatment of choice for a patient who has twin-twin transfusion syndrome?
Sir, first laser photocoagulation, sir. And
Okay, what is the name of the technique that you use for doing that?
Sir, I'm not sure about the technique.
Is it laser photocoagulation or is it radio frequency ablation?
Radio frequency ablation.
Okay, fine. And okay, ma'am, any other questions that you have?
No, sir. That's it. Yeah. Thank you.
Thank you, ma'am.
Sai,
Thank you,
Nitya.
sir. Thank you, sir.
Thank you. Next participant, Miss Sanjana, fourth year MBBS from MSRMC, Bangalore. Please turn on your video and share. Thank you. Share the PPT. Is it a problem, Sanjana?
No, sir. Just 1 minute. Sorry.
The other girl is ready. The Usrita Krishna.
Sita Krishna.
Okay, Sanjana is sharing, right? Yeah.
Start.
Am I audible?
Yes.
Good evening, esteemed faculty, fellow students. My name is Sanjana, final year MBBS from Ramaya Medical College, Bengaluru. So presenting a case of Mrs. XYZ, aged 28 years, hailing from Tumkur, educational qualification being BCom, homemaker by occupation, blood group is AB positive. Her husband, Mr. XYZ, aged 34 years, educational qualification being BCom, software engineer by occupation, and blood group being B positive. She belongs to an upper middle class according to modified Kupuswamy scale. She is a primi gravida. Her last menstrual period was 22nd of July 2024. Her expected delivery date was 28th of April 2025. Her period of gestation was 36 weeks plus 5 days. Her date of admission was 17th March 2025 and date of examination was 26th March 2025. She is a 28-year-old primi gravida, lone case of type 2 diabetes mellitus for 4 years on insulin, who came with history of 8 months of amenorrhea with the following complaints: decreased fetal movement since 1 day, fever since 5 days, and cough and cold since 5 days. So she was in her apparent state of health until 1 day ago when she experienced decreased fetal movements, and she complained of fever since 5 days, which was insidious in onset, low grade, intermittent, no diurnal variation, relieved upon taking paracetamol, and not associated with any rashes, chills, or rigor. The patient had also experienced cold and cough since 5 days, which is insidious in onset. Cough was of wet type, sputum was whitish in color, minimal in quantity, mucoid in consistency, non-blood stains, and non-foul smelling. There was no history of throat pain, difficulty in swallowing, ear pain, and ear discharge. There was no history of difficulty in breathing, noisy breathing. There was no history of foul smelling vaginal discharge, and no history of burning maturation. History of present pregnancy. In the first trimester, it was a spontaneous conception detected at 1 month of amenorrhea by a urine pregnancy test, confirmed by a scan. It was a booked case. Folic acid tablets were taken once a day. Antenatal visits was once every month, and dating scan, NTNB scans done, found to be normal. There was the antenatal, that is the first trimester, was uneventful with respect to complaints, and there was no history of radiation exposure. The patient had been taking insulin injections for the past 4 years. Second trimester, the quickening was felt at 5th month of pregnancy. The 2 doses of tetanus toxoid were given in the 4th and 5th month. Iron and folic acid tablets and calcium tablets were taken once a day regularly. OGCT was done. Raised blood sugar was found, which was 200 mg per dl. HbA1c was done, 5.5%. Anomaly scan done, found to be normal. Antenatal visits were once in 2 weeks, and second trimester was uneventful with respect to complaints. Third trimester, she continued to perceive fetal movements well until 1 day ago. The iron, folic acid, and calcium tablets were continued. Growth scan was done and found to be normal. Antenatal visits were once every week, and third trimester was also uneventful, except for the present complaints. Past history, the patient is a known case of type 2 diabetes mellitus since 4 years on insulin injections for the same. 25 units were taken before pregnancy, which was changed to 50 units during pregnancy. She takes 2 doses, 1 dose 30 minutes before a meal and 1 dose at night. No known comorbidities and no known allergies. Menstrual history, she attained menarche at 13 years of age, regular cycles of 30 days flow lasting for 4 to 5 days, changes 2 parts per day, no history of clots, dysmenorrhea, or menorrhagia. She was married for 2 years. It was a non-consanguineous marriage and no history of contraceptive use. There's an uneventful family history. There's no significant family history. Personal history, her diet was mixed. Appetite was good. It was adequate in calories and protein. Sleep was undisturbed. Bowel and bladder habits were normal, and there was no noted substance abuse. The general physical examination, the patient was moderately built, well-nourished, conscious, cooperative, oriented to time, place, and person. Her pre-pregnancy BMI was 19.5 kg per meter square. Present BMI is 22 kg per meter square. Her vitals were normal. There was no significant findings in the vitals. No significant findings on general physical examination as well. Per abdomen examination, on inspection, the shape of the abdomen was longitudinal, uniformly over-distended. Corresponding quadrants moved equally with respiration. The umbilicus was central and everted. Linea nigra, striatum was present. No scars or dilated veins, and hernial orifices were intact. On palpation, the fundal height corresponded to 36 weeks of gestation. The flanks were not full. Symphysiofundal height was 34 centimeter. On Leopold's maneuvers, on fundal grip, hard globular mass, which was independently ballotable, which is suggestive of a fetal head. Right lateral grip, there was no structures palpable due to the excessive amniotic fluid. Left lateral grip, there was smooth, continuous curvilinear resistance felt, suggestive of a spine. First pelvic grip, broad, soft, irregular mass, which is not independently ballotable, suggestive of breech. On auscultation, the fetal heart sounds were muffled. Systemic examination was normal. Summary, a 28-year-old preemie gravida hailing from Tumkur, homemaker by occupation, belonging to an upper-class family, married for 2 years, non-consanguineous marriage, was a known case of type 2 diabetes mellitus for 4 years, on insulin injections for the same. The last menstrual period being the 22nd of July 2024, period of gestation being 36 weeks and 5 days. She came with the complaints of decreased fetal movement since 1 day, fever since 5 days, and cough and cold since 5 days. She had an uneventful antenatal history as of the present. All scans have been done, found to be normal, and no significant family history. On examination, the abdomen was uniformly over-distended, fundal height corresponding to 36 weeks of gestation. The obstetric grips revealed breech presentation, and other system examination was normal. Provisional diagnosis, 28-year-old preemie gravida came with 8 months of amenorrhea, period of gestation being 36 weeks and 5 days, a known case of type 2 diabetes mellitus for 4 years on insulin, decreased fetal movements with breech presentation, and a possibility of polyhydramnios in upper respiratory tract infection. Thank you.
Good. Sanjana, can you please put the 7th or 8th slide, second trimester? Okay, fine. Yeah. So she's a known case of diabetes. Would you going to do a screening GTT test for them?
Yes, ma'am. Yes.
She's a known case of diabetes for the last 4 years?
Yes, ma'am. She is.
So why would you do a screening test again?
The thing is, initially, that is, according to the history that we have taken, the patient was like when she was pregnant, she was diagnosed with uncontrolled diabetes mellitus. So they wanted to confirm the glucose levels at that point of time.
She's been on insulin for the last 4 years, right?
Yes, ma'am.
Oh, fine. Now she has come with reduced fetal movements.
Yes, ma'am.
Okay, fine. Can you tell me what are the normal fetal movement count? How do you ask the patient, high-risk pregnancy patient, to make a DFMC, daily fetal movement count? Test for antepartum surveillance. Okay, what are the tests for fetal well-being you ask them to do generally in pregnancy, in pregnant women, low-risk pregnant women? What should be the normal fetal movement count generally now at this period of gestation? Term pregnancy.
10 kicks per in 24 hours, I think. She should be able to feel.
Okay. So she has, heart rate is also higher, right? She has 112 per minute, but she is afebrile now.
Yes, ma'am.
Okay. How will you manage your patient?
So management will be done, that is, in the beginning of the pregnancy, like she...
No, now how will you manage her? She has come with upper respiratory tract infection. She's term pregnancy.
Yes, ma'am.
Type 2 diabetes with reduced fetal movement.
Yes, ma'am. So she was started on antibiotics, as well as like with respect to her delivery, because of her decreased fetal movement, they were monitoring her for an early that is, they were planning to terminate pregnancy. So that is by around 38 weeks. So management for the pregnancy would
now
be
38 weeks, right?
36 plus 6 weeks.
Okay, with breech presentation. Fine.
Yes, ma'am. So they were planning for a C-section due to the breech presentation.
As of now, she's admitted only for fetal monitoring purpose and fever.
Yes, ma'am.
Oh. Sir, please go ahead.
Okay, thank you. Sanjana, what is Pedersen's hypothesis?
Sorry, sir.
What is Pedersen's hypothesis?
Not sure, sir. Sorry.
Okay. Next question is, your patient is at 36 weeks of gestation. Would you want 36 weeks, 5 days? Would you want to give her steroid cover, antenatal steroid cover, now that she has come to you with decreased fetal movements?
From when to when you give the steroids? Whenever they come with preterm label, no? Which gestational age to which gestational age you give steroid?
What are the recent most updates? What is the recent guideline on this?
Yes, sir. I think we would give steroids.
Do you think, will you give or will you not give? Because you giving steroid can push her into DKA, given that she is a diabetic already. So you need to be very judicious if you want to give or if
But
you don't want.
but over diabetes can cause respiratory distress in the newborn because of the delayed lung maturity. So steroids would probably be given. And
Probably. So you're still not sure about giving.
at 30, the normal steroids can be given at 32 weeks, 32 to 38 weeks,
Okay,
I
no
think.
problem. What is the commonest first trimester complication that you see in patients with chronic with over diabetes mellitus?
Sir, could you repeat the question?
What is the commonest first trimester complication that you see in patients with over diabetes mellitus?
First trimester. There can be an increased risk. There can be increased maternal infections as well.
Maternal infection can happen anytime in any in any of the trimesters. It can happen even postpartum. What is very specific to the first trimester?
Abortion.
Okay. Recurrent pregnancy loss. Why would there be abortion?
If there was uncontrolled diabetes, there might be.
But why? Why would that happen? Okay. Assume that your patient is the fetus is in cephalic position and you give it a trial of labor whenever you're delivering her. What are the complications that you need to guard against in the intrapartum period and in the postpartum period?
Complications during the intrapartum and the postpartum period.
Yes.
There is a high risk of congenital anomalies associated with
That
this.
is not something that would happen in the intrapartum and postpartum period. That is something that may have already occurred in the second trimester. So what is very specific to intrapartum and postpartum period in your patient?
There could be shoulder dystocia and
shoulder dystocia. Your patient also has polyhydramnios. What would that lead to?
There can be macrosomia. There can be.
Yeah, that will lead to shoulder dystocia. What about polyhydramnios? What will that lead to? It's okay. Radhika ma'am, any questions?
Yeah, no, that's good. Okay.
Okay. Thank you, Sanjana.
Thank you.
Thank you, people. Last participant, Krishna.
Yes, sir.
Yeah, try once, otherwise I'll share. There's a share option. Click on that and share your screen and open the PPT.
Is my screen visible?
Yes, it's visible now.
It's visible, ma'am.
Yeah, screen is visible. It's in the phone, I think. She's sharing through the phone, right?
Yeah, great. It now
It's
is
okay, doesn't matter. Yeah, you can present.
start now.
Good evening, respected judges and all my fellow delegates. So here is my case presentation. My patient named Mrs. XYZ of age 25, education 12th grade, hailing from Jangaon district. She came to OPD having last menstrual period of 27/8/2024 and expected delivery date of 3/6/2025. Her gestational age was 37 weeks and gestational score was Gravida 2, Para 1 and Light 1. She belonged to lower middle class according to modified Kupuswamy scale. A 25-year-old pregnant lady with amenorrhea of 9 months visited maternity hospital with complaints of reduced perception of fetal movements since 4 days, headache since 1 day, and swelling of legs since 1 day. Headache was throbbing like in nature. Bilateral pitting edema of grade 2 was observed over ankle. Perception of fetal movements were reduced to 2 to 4 per day, which were 10 to 15 earlier. Coming to history of presenting illness, she was apparently carrying pregnancy well 4 days back, but developed her current complaints. There was no history of epigastric pain, nausea and vomiting, blurred vision, reduced urinary output, bleeding per vagina or fever with rash. Coming to present obstetric history, she conceived this pregnancy spontaneously after non-consanguineous marriage of 5 years. Pregnancy was confirmed after 1 month of amenorrhea through UPT. She was a booked and registered case at government maternity hospital. She had no history of hyperemesis gravidarum, blurred vision, bleeding per vagina, epigastric pain, or abnormal urine output in any of the 3 trimesters. Only the current complaints, which was headache and pedal edema, were positive in 3rd trimester. Coming to past obstetric history, in her first pregnancy, a 2.5 kg healthy baby boy was delivered through normal vaginal delivery at full term after 2 years of marriage. Gestational hypertension was noted in this pregnancy. Menstrual history, she attended menarche at 13 years. Menstrual cycle was regular and cycles of 28 days, flow for 3 to 4 days. There was no history of dysmenorrhea, passage of clots, no significant abnormal history was noted. Coming to past and family history, no history of diabetes, thyroid disorders, asthma or epilepsy or other significant history. No history of hypertensive disorders of pregnancy in the family. Personal history, bowel and bladder habits were normal, no history of addictions, no other significant personal history was noted. Coming to general examination, she was conscious, cooperative and well-oriented to time, place and person. She was moderately built and nourished. And vitals revealed pulse rate was 90 beats per minute, respiratory rate was 17 breaths per minute, temperature was 98.4 degree Fahrenheit and blood pressure was 164 by 108 mmHg. There was no pallor, icterus, clubbing, lymphadenopathy. There was bilateral pitting edema of grade 2 was observed. Normal changes of bilateral breast of pregnancy was seen. Coming to systemic examination, CVS, CNS and respiratory system examination was found to be normal and no other significant history was noted. Coming to obstetric examination, inspection. Upon inspection, globular longitudinally distended abdomen, centrally everted umbilicus, linea nigra and stria gravidarum are seen. There were no scar marks, sinus or dilated veins. Upon palpation, symphysiofrontal height was 32 centimeters at 37 weeks, which is low. Abdominal girth was 92 centimeters at the level of the umbilicus. Uterus appeared smaller than gestational age. Fundal height lagged behind. So upon investigations, further digging deeper, complete blood profile was normal. Liver function test revealed mildly elevated liver enzymes. Renal function test revealed increased creatinine levels. Proteinuria was positive of dipstick 2+. Ultrasound revealed small fetus for gestational age with estimated fetal weight of less than 10%. Amniotic fluid index was less than 5 centimeters and biophysical profile score was 4/8. Coming to summary, a 25-year-old pregnant with amenorrhea of 9 months presented to OPD with the complaints presented. Having high BP, proteinuria positive, and having amniotic fluid index less than 5 centimeters and biophysical profile score suggests that it is pre-eclampsia along with intrauterine growth restriction. Yes,
okay. Usrita, what is the fundal height by palpation? Uterine height by palpation? Not symphysiofundal height measurement. Uterine height by palpation?
Ma'am, I didn't note it, ma'am. Uterine height by palpation.
Flanks were full in this case?
Ma'am?
Flanks were full?
Ma'am, they were not completely full, but a little bit, ma'am. There was reduced in amniotic fluid index, so they were not completely full.
Okay. She is a booked case, right?
Yes, ma'am.
This lady is booked and immunized. Could you have prevented pre-eclampsia? Maybe she had some risk factors.
Yes,
in the first trimester, if she was coming regularly to you, could you have prevented?
Ma'am, being noting her history of having gestational hypertension in the previous pregnancy, we could have taken preventive measures before, ma'am.
Like
having uterine artery Doppler, which can show a diastolic notch, or giving her aspirin.
When will you give the aspirin?
After 16 weeks, ma'am. 16 weeks of gestational pregnancy.
Anything else? You know about any other preventive factors?
Ma'am, monitoring BP regularly and noting any minute issues which are indicative of preeclampsia or hypertension in pregnancy.
Sir, please go ahead.
Okay, thank you, Dr. Radhika. Just like ma'am just asked regarding prediction of preeclampsia, could you tell me, Usrita, what are the other ways of predicting preeclampsia?
Sir, hypertension in early pregnancy, or if you're having
No, that is a
headache.
risk factor. That is a risk factor. Headache and everything, no. A proper predictor, just like uterine artery Doppler is one of them. Any other parameter that you can look for in the first trimester?
Maybe while during scans or USC abdomens.
No.
No.
Have you heard of something called as placental growth factor?
No, sir.
Okay. There is something called as placental growth factor. There is also measurement of SFL soluble FMS like tyrosine kinase 2, along with a few other things that you can, along with your dual marker, that can help you predict the risk of preeclampsia in future. No problem. Tell me, you mentioned aspirin can be used from 16 weeks. It is actually from 12 weeks of gestation that you can use. Could you tell me what is the mechanism of action that helps in preventing or delaying preeclampsia with aspirin?
Yes, sir. Sir, aspirin will release prostaglandins, which are vasodilatory agents for
Will
blood
release
vessels.
prostaglandins. That is like
And
misoprostol. Then why not give misoprostol in the first trimester?
they aid in they inhibit thromboxane A2 also, sir.
But you said they release.
Low dose. At low dose, what exactly is the action?
Low dose aspirin. It is an
It will inhibit prostaglandins, not release. It will inhibit prostaglandins.
yes, sir. COX-2 enzyme.
Okay. And what is exactly low dose? How much is that? How much is low dose?
I'm not sure, sir.
Okay. 75 to 150 milligrams. Till 150 it is low dose. Okay. Apart from that, could you tell me what are the other causes of fetal growth restriction, IUGR, apart from preeclampsia?
Yes, sir. Abruptio placenta.
No,
Or
that is a cause of fetal growth restriction.
fetal growth. Oh, multiple pregnancies, sir.
Okay, good. What else?
Malnourishment.
Malnourishment. Okay. What else?
Drug addictions or
What are the commoner causes? I mean, how often do you get women who are abusing drugs and have fetal growth restriction because of that? Very expensive. Those drugs that cause fetal growth restriction are very expensive. Even I can't afford them. Anything else? A little more common.
no, sir.
We say no uterine height less than the period of amenorrhea. These are the causes.
Things like intrauterine infections, congenital anomalies, many.
Yes, sir.
Okay. Ma'am, any other questions?
No, sir. That's it.
That's it. Yeah.
Thank you.
Thank you, Srita.
Thank you, sir.
So we are concluding, right?
Yeah. Thank you, all the participants, for staying till here. Thank you for the presentation. To the judges, thank you for making time to this case presentation. Results will be announced in the WhatsApp group directly after calculating the scores.
Thank you, Dr. Radhika. Thank you, Dr. Radhika, for being a great co-judge. It was great knowing you. And thank you, Satvik, for conducting it so smoothly.
Thank you, sir. Thank you for coming.
Thank you, sir.
Thank you.